How is everybody doing? All right. All right, give me 1 second here to get my questions. All right. So how's everybody doing? All right, so we're going to do gastroenterology tonight. I just had a couple of questions for you guys because some of you sent me emails and I thought that these were really good questions. Um, so, uh, so look at this. If the patient has active tuberculosis, right? Active tuberculosis, there's state laws. If this patient refuses to take medication, we can keep them in the hospital in isolation and force them to take medications. And we have to report active tuberculosis to the state. In some places, they report it up to the CDC. So Raja and a couple of other people had questions about that. We can't do anything if the patient refuses to want to be treated for latent tuberculosis. See, because the risk is not that they don't pose a risk to anybody. They're non-infectious. Their infectivity is zero. Everybody understand that? Is my voice okay? It's probably your thing. Okay, so listen, if you guys are getting problems with the picture or something like that, talk to the text. It's probably not me. Otherwise, everybody would have had a problem. It's a problem with your instrument. Okay, so everybody okay with that? So latent TB, we can't do anything about it, but active tuberculosis, they pose a threat to society. You could put them in the hospital. You could force them to be treated. Okay? All right, very good. When we treat patients for asthma exacerbation, we treat them for 2 weeks, right, with corticosteroids. We start with IV and we flip over to oral. They do about 10 to 14 days. Then, so you finish that spurt of steroids and you go back to your regular treatment. What's the regular treatment? What are most adults getting? Right, short acting plus inhaled corticosteroids. Now, I saw a question that now I got concerned. So remember, that's what they go back to. So let me finish this and I'll go back to that question. So they go back to their regular treatment after 2 weeks of corticosteroids. Okay? You guys don't need to know doses, right? So there's nothing that they ask doses. They don't ask how many times. They don't ask doses. Everybody understand that? What's the difference between COPD exacerbation and asthma exacerbation? Really, the only difference is that antibiotics are given in COPD all the time. I mean, in the exacerbation, in the treatment, I apologize. And we use primarily ipratropium, right? Otherwise, it's pretty much the same. Okay, everybody understand that? So the total amount of steroids in asthma and COPD is about 10 to 14 days. Okay? Everybody okay with that? All right. So I saw a question now that got me a little worried. I mean, I know you know this, but I'm worried when I see this question. So somebody asked about, so there's no ambulatory treatment of tuberculosis. I didn't say that. I said yesterday, in fact, we went over that when you treat active tuberculosis, you isolate them for about 2 weeks. You keep them in the hospital until 3-AFB is negative, right? Then we discharge them home to ambulatory treatment for how many months? Total of 6 months. Okay, so there's this thing called delivery of treatment, DOT, that a lot of cities have. So you make sure that this patient's getting it, so somebody goes to their house, like a nurse or a nurse practitioner or a PA, and make sure they're taking the medication. But they get treatment for 6 months. Everybody okay with that? All right, let's go back to gastroenterology, and if you guys have any more questions, right, and then we'll talk about it, okay? All right, so look at here. This patient says, my belly is swollen and it hurts. Well, in terms of GI, when people's belly is swollen and it hurts, you probably should be thinking about a couple things. A 58-year-old woman comes to the ED with fever, abdominal pain, and distension. She has ascites. She has wasting and anorexia. She has severe itching. She takes no medications, and she is a former injectable drug abuser and was discharged from the alcohol detoxification a few months ago. Right? So ascites. Right? So Moan says cirrhosis. From what? Cirrhosis from what? All right. So Euclid said hepatitis, chronic hepatitis, right? Because maybe she's an injectable drug user and she's got hepatitis C. Right? Hepatitis C is the most common cause of what? Of cirrhosis in this country. Right? The most common cause of cirrhosis in this country is hepatitis C. Now she's got other risks, maybe it's hepatitis B too, right? So that is another chronic form. And then you guys said alcoholic liver disease. So that's probably number 2 cause of cirrhosis in this country. So she's got both risk factors, right? So chronic hepatitis, right, causing cirrhosis. Alcoholic liver disease causing cirrhosis in this patient. Definitely possibilities. And then you guys talked about bacterial peritonitis. So now you got ascites and it gets worse because you got an infection there. And this is called spontaneous bacterial peritonitis, or SBP. That's a complication of pre-existing ascites, right? Okay, very good. Now, can you guys give me other? Good. Daddy says ovarian cancer with carcinomatosis. So it doesn't have to be from the liver all the time, right? You could have other things like cancer, ovarian cancer, right? You could have other reasons to have cirrhosis, like biliary cirrhosis or sclerosing cholangitis. You could even have heart failure causing it, right? So ascites is broken down into 2 categories. One, you got portal hypertension, right? The other one, you don't. So you could have ascites with no portal hypertension if you got cancer or an infection in the abdomen. So that's called non-portal hypertension related ascites. That's the one that you guys were talking about is associated with ovarian cancer. That's the one they like to ask on the USMLE. They tell you this woman drinks or is an alcoholic and she has ascites, and you assume it's from cirrhosis, and you probably are right. But the thing you didn't think about is maybe it's not. Maybe she has ovarian cancer. And David says you need a paracentesis. That's the way you figure it out. Right? So one category is non-portal hypertension. The other one is portal hypertension. That's cirrhosis, heart failure. So if this guy's got Wilson's disease, if he's got sclerosing cholangitis, he's got biliary cirrhosis, right? He's got hemochromatosis, he's got hepatitis C, etc., it'll be all portal hypertension, right? Everybody okay with that? So things that cause portal hypertension, right? Things that cause ascites without portal hypertension. Portal hypertension is cardiac and cirrhosis. And now you can think about all the causes of cirrhosis. Non-portal hypertension related ascites infections like tuberculosis. In other parts of the world, TB peritonitis is common. And then ovarian cancer. Please be careful about ovarian cancer. They love to ask about that. Okay, very good. So this patient appears disheveled. She's cachected. She's got a distended abdomen. She's got low-grade fever, right? So maybe the stuff about SPP is a possibility. Her blood pressure is okay. Her pulse is elevated. Her respiratory rate is 22. She's got poor dentition, parotid enlargement. That happens a lot with alcoholics. She's got scleral icterus. Her lungs are clear. Her heart has a regular rate and rhythm. So far, I'm seeing that this patient likely has, jaundice, probably related to the cirrhosis, and a low-grade fever. She's got a distended, tympanic, and tender abdomen with shifting dullness. The liver is not palpable. The spleen tip is palpable 3 centimeters below the costal margin, right? So what does that mean to you? If in a patient with jaundice you have a big spleen, likely portal hypertension. Okay, very good. And then look at here, palmar erythema, spider angiomata, right? Flapping tremor, what is this? These are stigmata of what? Stigmata of chronic liver disease, right? Estrogen excess, right? Chronic liver failure. Be careful, because you could have acute liver failure, right? You could have acute liver failure, and you don't get this stuff, right? So somebody gets fulminant hepatic failure, from Tylenol toxicity, they don't get this stuff. Who gets this stuff? People that have had it for a long time. So these are stigmata of chronic liver disease, right? So now I don't think about Tylenol toxicity and stuff like that, right? What do I look for? I look for hepatitis C, alcoholic liver disease, hemochromatosis, chronic things. Stigmata of chronic liver disease are very, very important. Okay? Everybody okay with that? All right. So let's look at here. The differential diagnosis here, we said alcoholic cirrhosis, right? And chronic hepatitis is, right? You could get acute on viral hepatitis, but, right, this is not acute viral hepatitis. The reason they put acute here is because you could get acute viral hepatitis on top of chronic liver disease. But in terms of what's causing the cirrhosis, right, this is chronic hepatitis. And chronic hepatitis, right, are the ones that we see that are associated with chronic liver disease are Hep C and Hep B. See, I put Hep C first because this right now is the most common cause of chronic liver disease in this country and probably the Western world. You guys also mentioned bacterial peritonitis. So maybe this person had a little bit of fluid in the belly, didn't notice before, and now it got infected. Right? So where did they get infected? Where did they get this spontaneous bacterial peritonitis from? Where did they get this from? All right, Euclid said the bowel, translocation from the bowel. That's the right answer. So if it's from the bowel, what kind of bugs are we talking about? If it's from the bowel. Good. Yvonne says E. coli, anaerobes, Klebsiella. All right, you guys got it. And then you guys mentioned also peritoneal carcinomatosis secondary to ovarian cancer. Please remember this. They love to ask about peritoneal carcinomatosis in a patient that drinks. So you right away you think about alcoholic liver disease, but it's this. right? You forgot to do the full evaluation. So be careful. All right. So what are other things? All right. So these are the most common ones, right? These are the ones, the 3, 4 that we're going to think about right away in this patient, given her history, right? All right. So what are other things? Okay. Maybe she's got hemochromatosis. Okay. Maybe she's got Wilson's disease. Maybe she's got chronic liver disease and now she's got cancer. With or without peritoneal carcinomatosis, she's got a hepatoma. So I like that, right? Hepatoma. Maybe she's got, one of these weird immune diseases like primary biliary cirrhosis, primary sclerosing cholangitis, right? Maybe she's got tuberculosis. See, you got to think about your differential diagnosis a little bit more in case this doesn't pan out, right? Maybe she's got TB of her abdomen, right? Who knows? So there's other things to think about here, okay? Everybody okay with that? But yeah, the people that said alcoholic liver disease, right? So there's even alpha-1 antitrypsin deficiency and stuff like that, right? You may have a thrombus there, like Budd-Chiari syndrome, et cetera, et cetera. But these 4 that we put in the differential diagnosis here, given her history, are likely the most common ones. Okay? All right, so now tell me some tests that you guys want. You want to get regular tests, and you have to do something. Good. So Sally says, get the PT-PTT, get the LFTs, get the CBC, right? Get the comprehensive panel, get the BUN creatinine and stuff like that. Look at the albumin. All that stuff helps us a lot. But what's the most important test in this patient? All right, so David says paracentesis. Guys, what is the most important test? If the patient has has fluid in the belly, what do we always have to do? We always have to tap it. We'll talk about the 2 important tests here. We always have to do paracentesis, right? What if we have fluid in the lung, a pleural effusion? What do? What's the first test? We tap again. We got fluid in the belly, we tap. We got fluid in the lung, we tap. We got fluid in the joint, monoarthritis, we tap. See, you always go for the fluid. Right? Everybody understand that? So this patient, the most important thing here, right, after you get the regular tests and all that stuff, is to do paracentesis. So why do you want to do now? See, now, why do you want to do paracentesis? Right, so Indra says we'll tell you about the etiology. That's right. Because you'll get the SAG. And you'll also, Kavitha says, we'll rule out SPP. So the 2 reasons why we get paracentesis is to confirm the etiology, or at least be pretty sure about the etiology, because you're looking at the gradient, right? And to rule out infection. So Sarah said it very nicely. We rule out infection. What infection? SPP. And we look at the gradient to make sure there's portal hypertension. We could attribute it to what? Cirrhosis. Okay? And then if it's not cirrhosis, then you got to look for cancer. You got to do for other things. You got to do more tests. Okay? Everybody understand that? So the single most important test here is what? A paracentesis. Okay, very, very important. All right, so let's look at a couple of these things. All right, so we got the PT and the PTT and the INR. All right, everybody knows what the INR is, right? So somebody asked me the other day what an INR was. I just want to make sure this is another way to standardize the pro time, right? International normalized ratio. It's just another way to look at the pro time because there's so much variability. Okay? An INR of less than 1 is normal. So this patient has 1.4. So it's definitely elevated. Okay? So what does that mean? Well, since a lot of the factors, right, except 8, are synthesized by the liver, right, these are the first markers to go up. with liver disease, right? This is a very important part of looking at liver function. Be careful, because somebody mentioned before, watch the liver test like the ALT, AST. Sometimes with cirrhosis, they normalize. I like that. Somebody mentioned that. So they asked this question, what happens to the liver tests, with cirrhosis? They actually normalized, right? So you got to look at the PT-INR, right? The PTT and stuff like that. The PT-INR is probably the most important one, right? You have to look at the bilirubin. You have to look at the albumin, okay? So we look at the CBC also, right? So Rodrigo says these LFTs don't measure function. They see when the liver becomes fibrotic, cirrhotic, there's no cells to give these enzymes out, so they normalize. They come back to normal. In fact, they go, below normal, right? So I had a student one time, and she said, Mr. Jones, his hepatitis C is doing better, right? And I said, that's great. And she says, well, his AST/ALT went from 200 to 40. And, maybe he is doing better, but one of the reasons the AST/ALT goes down to normal is because the liver disease is getting worse. And that's what was happening to this poor guy. Okay? All right. The CBC and the peripheral smear is important, right? We want to look for leukocytosis. A lot of these patients have anemia. They have low platelets because of the hypersplenism and because of the liver dysfunction. And they also have an elevated MCV a lot of times, probably from alcohol use and sometimes the liver disease, right? So this patient's white cell count looks okay. The hemoglobin is a little bit low, right? The platelets are low. You could attribute that to liver disease and hypersplenism. The MCV is definitely elevated, and the BUN creatinine is probably okay. Why do we want to take a look at the BUN creatinine in people with liver disease? Why is it very important? Very important. Yeah, because there's this thing called hepatorenal syndrome, where people with chronic liver disease, they get pre-renal azothemia. They get pre-renal azothemia, and they develop this disease called hepatorenal syndrome. Very, very bad news when that happens, because these patients, the mortality goes up tenfold. In fact, these patients, most of them die when they develop this hepatorenal syndrome, right? David says they require transplant, they require like a million other things. Okay? So very, very important here to look at this. Okay, a couple of more tests that you guys asked for. You guys asked for the AST and the comprehensive panel. So the AST is elevated, right? And the ALT is also elevated. Okay, now what do you notice here? AST is 200 and ALT is 100. So Ryan says it's 2 to 1, right? And what's that usually consistent with? When your AST is much more high than your ALT, that's usually consistent with alcohol. All the other diseases do what? They cause the ALT to be much higher, right? So if you got Hep C, Hep B, hemochromatosis, right? Wilson's disease, alpha-1 antitrypsin deficiency, all the viral ones Shari said, they are, the ALT is more higher than the AST, or they're about the same. But you don't see this marked increase of AST compared to your ALT. Okay? Everybody okay with that? All right. The alkaline phosphatase here is a little bit elevated, right? So maybe 2 times the normal. Okay? So what's the alkaline phosphatase a marker of? So, when you have severe disease, everything goes up. Right. So obstruction and pressure, right? So when is typically what liver diseases cause the alkaline phosphatase to be very high? Okay, PBC, okay, cholangitis, okay, all right. So what do we call these diseases? See, when your AST/ALT is more increased, that's hepatocellular damage, right? When your alkaline phosphatase goes up, that's what? Posthepatic or obstructive, right? It's called obstructive, like primary sclerosing cholangitis, biliary cirrhosis, cancer in the head of the pancreas, cholangiocarcinoma, right? Uh, a stone in the common bile duct, etc., etc. Right? Everybody okay with that? All right. And then your total bilirubin here is elevated, right? Yes, it could be, but people with bone disease don't have jaundice, right? We're talking about an increased alkaline phosphatase in somebody with jaundice in the context of liver disease, right? So people that have, uh, uh, bone disease, their alkaline phosphatase could be in the thousands, but they don't have this stuff, right? So we're not talking about an isolated elevation of alkaline phosphatase here, right? Everybody okay with that? All right, so look at this. So the question on the USMLE is, in this patient, the total bilirubin is elevated. Which one of the types of bilirubin is most likely to take most part of the elevation in bilirubin? The direct, right? So if it was indirect, we're talking about hemolysis and stuff like that. This is conjugated, okay? The albumin is low. Should have been 4, right? It's low. Okay, so far, what do you guys think? What is this consistent with? Right, so alcohol, right? Cirrhosis, definitely likely to alcohol. Okay, we still don't have a diagnosis for sure, but that's our presumption. Everybody okay with that? We're probably on the right track here. So how are we going to know for sure it's not hepatitis C, right? Or hepatitis B? Yeah, we don't have to, you could biopsy, but hepatitis panels. All right, so that's some of the tests we're going to get. See, the AST/ALT ratio, that's just indicative, right? But you want to confirm with viral serology, right? Everybody okay with that? So in acute hepatitis, which bilirubin would be elevated? It's still hepatocellular, right? It's still damage of the hepatocytes. It's direct. Why would it be indirect? See, AST/ALT increase with conjugated bilirubin is the typical hepatocellular damage. If it was indirect, it would be hemolysis. Everybody understand that? Hemolysis is the typical unconjugated. Or what's the most common cause of unconjugated bilirubinemia? Anybody know? Worldwide. Ooh, Ryan got it. Joubert syndrome, not hemolysis. Joubert syndrome. 10% of the population has Joubert syndrome, right? So this is a benign disease. People get a little sick, they get a little jaundice and stuff like that. It's a conjugation problem. They don't conjugate well. They have a deficiency in conjugation. So your unconjugated bilirubin is elevated. So that's not the case with acute hepatitis though, right? Everybody okay with that? Okay, very good. All right, so look at here now. All right, so on the physical examination, this is important to remember. We got to remember stigmata of chronic liver disease. Chronic liver disease, very important. Spider angiomata, ascites, cat medusa. This patient didn't have it. Splenomegaly, palmar erythema. Be careful. They may want you to tell the difference between somebody who has chronic liver disease and has now cirrhosis, and somebody who has fulminant hepatic failure, like from Tylenol toxicity. Okay? Okay, so be careful about lethargy in patients with liver disease, right? You got to be careful about hepatic encephalopathy. So some of these patients are confused. Hepatic encephalopathy, the typical hepatic encephalopathy, they have the reversal of the sleep-wake cycle. So they're confused. They wake up in the middle of the night. They're going to go, to work and stuff like that, right? This patient didn't have that, but we have to be careful, okay? Also, I asked you, right? No, hepatitis E, Sarah, is an acute form of hepatitis. It's like hepatitis A. Hepatitis C is you get fulminant hepatic failure, or you don't get anything. Okay? You don't get chronic. Chronic is C and B. A doesn't cause chronic. E doesn't cause chronic. Delta doesn't cause chronic. It kills you if you have replicating. Right. So there's not only the, ABCs of hepatitis. You could get CMV. You could get Epstein-Barr. You could get a lot of other viruses. You could get herpes. Okay? Everybody okay with that? Stigmata of chronic liver disease is like saying stigmata of cirrhosis, right? Of chronic liver disease. See, this cirrhosis was going on for a long time. Everybody okay with that? All right, very good. So let me finish with this because we're flapping back and forth. We're going to talk about management of hepatic encephalopathy. So just relax. So I also asked you to be careful about the female patient with a history of significant alcohol abuse. When they have new ascites, this may be alcoholic liver disease, which is most likely, right? But you also have to remember to consider ovarian cancer. I told you they love to ask about this because people miss the diagnosis. So look for it. Okay, don't always assume because this person says I drink that the ascites is from cirrhosis. Okay, so a couple of basic signs correlates. So portosystemic shunting allows thiol, sulfide, trimethylamine to pass into the lungs. This leads to the odor of fetor hepaticus, the sweet, feces and stuff like that that people used to talk about in the old textbooks. Spider angiomata are vascular lesions, right? They occur, somebody mentioned it before, due to the rise in estradiol, right? The liver typically clears estradiol. So this question they've asked about in step one, and they kind of ask it clinically as a basic science correlate sometimes in step three and even in step two. Okay? We said the big clinical pearl is that when a patient has ascites, what do we always have to do? We have to do paracentesis. Okay? Even if the cause is obvious, please do it and figure out what? Two things. One is the SAG, and the other one is the white cell count, right? Why do we want to do that? Because we want to find out the cause, that's from the SAG, right? And the other one is the white cell count, right? Because we want to look at the absolute polys, right? Because we want to rule out bacterial peritonitis. See, bacterial peritonitis, we don't wait for the cultures. If we wait for the cultures, we'll never find anything. We get the leukocytes, the polys, and if they're over 250 or above, absolute polys, absolute neutrophils, 250 or above, this patient has SBP. Everybody understand that? You don't wait for the cultures. Okay? All right, now, who knows? How do we get the SAG? How do we get the albumin ascites gradient. How do we get that? How do we figure that out? So we do paracentesis, but how do we get the SAG? Because if it's over 1.1, 1.1 and above, it's portal hypertension. Ascites, good. Right, so look at this. All you do is you get the serum albumin, right? Let's say it's 4, okay? And then the ascites albumin, okay, equals 2. It's called a gradient, but it's not really a gradient. All it is you subtract the lower from the higher. That's it. It's a subtraction. So what's the gradient here? You just do subtraction from the low to the high. Right, so it's 2, right? Okay, so what does that mean? What does that mean? It's elevated. Okay, very good. What does that mean? Arturo, it's elevated. Very good. Okay? Portal hypertension. So what's the cause? Portal hypertension, cirrhosis, or what's the other one? Heart failure. We have no evidence of heart failure in her. We have history of drinking and stuff like that. So what do you think the cause is? Probably cirrhosis, right? So that's how we kind of figure it out. Now, what if it came back less than 1.1? What if it came like 0.8, right? Now you're worried about cancer, tuberculosis, and, business like that. Okay? Everybody okay with that? All right. So we got to remember this. This is big deal in medicine. If your SAG is 1.1 or above, that's portal hypertension, right? Cirrhosis, cardiovascular disease, and if you've got a thrombus there, right? And then if your SAG is less than 1.1, right? So portal hypertension now is absent. All right, so now you've got peritoneal carcinomatosis, right? Like tuberculosis, and then of course nephrotic syndrome and pancreatic disease, etc., etc. Okay, the 2 I need you to remember is right here: cancer and TB. Please, if you don't want to remember those 2, please remember peritoneal carcinomatosis. Okay? So Jose says, is that a transudate? So they don't call in the abdominal fluid, they don't call it transudate versus exudate, but theoretically, right? A SAG of less than 1.1 is an exudate, right? It's an exudate. That's what, theoretically, okay? A SAG of over 1.1, so now you got a systemic process, right? With portal hypertension, this is a transudate. Okay? Everybody understand that? They don't use that concept, but it's good to, that they used to do it this way, 20, 30 years ago. But now they just use the SAG, and it's basically very sensitive and specific. Okay? Everybody okay with that? Okay, very good. Okay, so let's finish up this case here, right? So look at here. So we got to remember, you guys mentioned, right? Sudden worsening of ascites, rule out hepatoma, right? Bacterial peritonitis or viral hepatitis. Watch this one. They mean this guy's got liver disease already, and they got viral hepatitis now on top of what they have already. All right, so you could get that. You could have cirrhosis and then now develop hepatitis A, right? Or people that have hepatitis B, what do they get? Sometimes they get hepatitis D, Delta virus, right? And stuff like that. So that's why we always have to repeat paracentesis in people with worsening ascites, even if we know the causes. So that's the clinical pearl here that they want you to know for the USMLE. And please, you guys mentioned it before, make sure you look for hepatoma. If the patient has cirrhosis, remember, if you got cirrhosis, your risk for cancer goes up tenfold, right? So what's the number one cause of cirrhosis in this country? I just said it before, hepatitis C. Why is this important? There's drugs to treat hepatitis C now, to cure it. All right. So what's the most common cause of hepatocellular carcinoma in this country? Hepatitis C again. Same thing. Same thing. If it's the most common cause of cirrhosis and hepatitis and stuff like that, then it's the most common cause of hepatoma. Okay? All right, very good. All right, so further tests here. You guys asked for hepatitis serologies, negative. The paracentesis, WBCs are 50, right? Gram stain and culture and stuff like that, negative. Iron studies normal, ceruloplasmin levels normal, alpha-1 antitrypsin normal, antimitochondrial antibodies. This is for biliary cirrhosis, right? And the liver ultrasound, right, for mass, right, shows no evidence of mass. Okay? So what do you guys think? What do you guys think? Rodrigo says alcohol, right? So we ruled out hemochromatosis, Wilson's disease, alpha-1 antitrypsin, biliary cirrhosis, and that stuff, hepatitis B and C. So we're back to what? Alcoholic liver disease. So look at this. White cell count of 50. What does that tell you? No SPP. Remember, 250 or above. There you go. All right. So let's close up this case. What do we do for this patient? What do we do for this patient? What's our goal? Tell him to stop drinking. Refer him to Alcoholics Anonymous. Please watch stuff like that. You have to put it down. Okay? All right. So now Atif said we treat the liver disease. We give him salt restriction, lactulose, diuretics, right? Diuretics, spironolactone, and furosemide, right? And then sometimes if they have a lot of fluid in their belly, we do paracentesis. Now it's therapeutic paracentesis, right? We do endoscopies once every year or every couple of years to make sure they don't have varices. Because if they have varices, we have to put them on a beta blocker, right? So all this stuff we have to do. These patients are very, very complicated. Nobody wants to take care of these patients anymore. Very, very difficult patients. So Alcoholics Anonymous, tell them to stop drinking, salt restriction, lactulose, give them propanolol or nadolol. If they have varices, put them on spironolactone and furosemide. Okay? Liver transplant. Listen, they got to stop drinking though, right? Remember, you can refer people with alcoholic liver disease to transplant, but they have to stop drinking for 6 months, right? Edward says 6 months, and they have to have social support. Be careful, social support is a big deal in these cases. Okay? All right, very good. So we just talked about this. Let's do one quick case here, and we'll take a little break. Okay? I'm vomiting blood. All right, what do you guys think? I'm vomiting blood. Doesn't sound good, right? All right, so 72-year-old man comes to the emergency department vomiting blood. He's got a history of alcohol abuse and a couple of GI bleeds in the past, right? He was on a bench earlier, an hour ago, was found by emergency workers in a pool of blood on the sidewalk. All right? What do you guys think? So Yvonne says esophageal varices. Anything else? Okay, Indu says Mallory Weiss. Very good. All right, those are good choices. How about peptic ulcer disease? Okay, but you guys are thinking what? You're thinking what? Upper GI bleed, right? Right? Upper GI bleed. Very good. All right, so now we got to stabilize him, right? All right, his blood pressure is 80 over power. Ooh, it's not good. Pulse is 125, right? He's stuporous. He's got scleral icterus. He's got gynecomastia and spider angiomata. So what are these? What are these? What are they telling you here? What are those findings? important about? Stigmata of chronic liver disease. This patient, whatever he's had in terms of his liver, it's been going on for a long time. His cardiovascular exam is normal, except the tachycardia, right? The chest is clear to auscultation. The abdomen is soft, non-tender. Rectal exam is significant for melanoma. Okay? So what do you guys think? Esophageal varices, peptic ulcer disease, Mallory-Weiss, right? Anything else you guys are worried about? Now, Borderheim syndrome is, remember, Borderheim syndrome is a transmural perforation of the esophagus. They don't have a lot of vomiting. They can, but they don't always have to have that. On the physical exam, right, we should have find, crunchy noises, in the chest and stuff like that, because once you perforate your esophagus, right, you get air in the mediastinum. And what else do you get? Yeah, so you get, polymicrobial and a chemical mediastinitis. Bad news. So hopefully this guy doesn't have it. Mallory-Weiss is a superficial tear, right? That's different. Right? So I don't hear anything about subcutaneous emphysema here. I don't hear anything about, abnormal findings in the lungs and stuff like that. So I hope that this is okay. All right? Okay, very good. So they said varices, right? Okay. They said Mallory-Weiss tear, erosive gastritis, very common, right? Peptic ulcer bleeding. All right. So tell me, what do I do next? Okay? Be careful. A patient that's very sick, what do you got to do? You got to stabilize him first. Right? So, you call your friend, the gastroenterologist, come in and scope this guy. He says, yeah, I'm watching the game now. Why don't you stabilize him first, right? And I'll come and see him later. Okay, this patient eventually needs an upper endoscopy, right? But what do you need to do first? You need to stabilize the patient. Okay? How do you stabilize the patient? You put large bore catheters, right? And you give them a lot of IV fluids, right? You give them thiamine and stuff like that. Okay, so in the GI bleed, the initial management, right, is the same no matter what the cause is. The focus is stabilize the patient, right? We put 2 large bore IV lines and we start fluids, right? So normal saline, the medicine people like normal saline. Okay, it's good to use. You want to use crystalloid or Ringer's lactate or whatever you want, that's fine also. Okay? Make sure you give them enough so you keep the systolic blood pressure above 90. Right? And what you try to do, keep the blood pressure above 90, heart rate below 90. Right? Those two are important. If you do that, the patient's going to have normal urine output, etc., etc. Okay? So remember, 90-90. Less than 90, right? Heart rate, over 90, blood pressure. Okay? Listen, they're going to try to snag you guys here on a case. They're going to say, well, how do you make the diagnosis? You don't care what the diagnosis is here. You have to stabilize the patient. I can't scope this guy or do anything else and get labs on him, get him for an x-ray, unless I stabilize the patient. That's the same for an upper GI bleed of any type and a lower GI bleed of any type. This guy will go to the ICU for at least a day. Okay? All right. Now, other things we got to do. We got to get a CBC, a biochemistry profile, and a PT-PTT. We want to see a baseline, and we want to see how bad his bleeding diathesis is and how bad his liver disease is. The reason for the biochemical profile, right, is important because a lot of these patients have electrolyte problems. And why? Because with bleeding, with a GI bleed, you could get pre-renal azothemia. So you want to look at that and get a baseline and go from there. If the patient needs a transfusion, you have to type and cross the patient and transfuse. If they have a coagulopathy, right, you use fresh frozen plasma. Okay? Everybody okay with that? Right? So it's very difficult. There's no test to assess how much fluid this patient has lost. right? You give enough fluids back to do what? To keep the 90-90s, right? Everybody remember that? 90-90. Okay? There you go. See, because this guy says, well, I didn't bleed a lot, or I bled a little, or this guy is like out of it. So it's very hard to assess. See, that's why it's better to do this with vitals. It's much easier to do it. Okay? Now, this patient will require an endoscopy. If they have varices, they will also need a therapeutic intervention. What am I talking about therapeutic intervention? Banding, right? And stuff like that. Band the varices, etc. Okay? Now, look at this. Sometimes the patient, you need to assess if there's ongoing bleeding, right? Because sometimes, the bleeding stops, right? Most of the time, right? So, you talk to the GI fellow, you tell him to come in and see this patient. This guy says, listen, I'll see him tomorrow morning, right? So Rodrigo says, but if I put an NG tube and I find bright blood, right, active bleeding, I called this guy back and I said, well, listen, bud, first of all, we can't stabilize this guy's blood pressure and he has active bleeding. And he says, how do you know? You say, because I put an NG tube and I found bright blood. Okay, so it's a way to figure out if there's active bleeding. You don't have to do it in everybody, but in people you're concerned for active bleeding, that is really the way to rule it out. If you put the nasogastric tube in, please, after you figured it out, you flushed it with a little water, patient, doesn't have bleeding, take it out. There's no reason to keep the NG tube in there. No reason. Okay? It's just to assess active bleeding. Okay, so the hemoglobin is low. The platelets are low. Right? The sodium is okay. It's borderline okay. The BUN is elevated, right? With the creatinine a little bit elevated, right? The BUN is more elevated than the creatinine. So maybe this prerenal azothemia is affecting kidney function, right? Everybody okay with that? Prerenal. There you go. The bilirubin is definitely elevated, right? The AST is markedly elevated. Everybody see that? So 3 arrows up, right? Where the ALT is only 80, right? So this is probably consistent with what? Alcoholic liver disease. The alkaline phosphatase may be a little bit elevated, so this is not a big deal. This is not a big contributor. The ProTime and the PTT are elevated. So this guy is in trouble, right? Because his bilirubin is elevated, his ProTime is elevated. This guy's got cirrhosis, and I can see that on the exam. It makes sense, right? So Eric said, if they ask, how do you correct that? The answer is I give fresh frozen plasma, right? Now, you remember, you can't give people a liver transplant if they're active alcoholics. They have to stop 6 months, okay? So this guy wouldn't be a transplant candidate, unfortunately. Listen, I didn't say if you drink, you don't get a liver transplant, right? No, but if there's a person is an active drinker, it's very difficult to put him on a transplant list. Whether you feel, ethical about that or not, it's very difficult to do that. They wouldn't have good outcomes. Okay? All right, very good. So look at here. The patient has bright red blood, right? It's upper GI bleeding, right? Has several possible etiologies. We talked about varices, etc., Mallory-Weiss tear, gastritis. Okay, very good. What do we have to do? This patient has to get an endoscopy. Remember, upper GI bleeding, upper GI bleeding, upper GI bleeding always has to get an endoscopy before they leave the hospital. Okay? You stabilize them, right? And then you do the upper endoscopy. This is for everyone. Okay? You don't let a patient go home for USMLE step 3 and even step 2. Don't let them go home unless they get the endoscopy. When it's a lower GI bleed, it's different. They stop with the lower GI bleed. We watch them 24 hours, send them home. and then you do the colonoscopy in the outpatient setting. But here, you got to be careful because they could have some type of serious bleeding. Most of the time they don't, but just, you have to rule it out. So this guy actually does, right? Look at here. They got varices with cherry red spots and a clot. The rest of the exam is normal, right? So what does that mean? The red spots, what are they trying to tell you? And the rest of the endoscopy is normal. Recent bleed, right? And it's healing now, but it's a recent bleed, okay? You banned the varices, okay? All right. So now what do you have to do more now, based on what we've said? What do you have to do more? So they stop, listen, if they have active bleeding, you got to give them octreotide, somatostatin, vasopressin, and stuff like that. But this guy stopped bleeding now, right? So now you're going to watch him in the ICU for 24, 48 hours, right? Because you're worried about their rebleeding. But what I'm saying is, the question is this: how do you reduce further esophageal bleeding? So the answer was propranolol. Okay, but propranolol wasn't an answer. That was an option, I mean. So what's the other non-selective beta blocker that studies have been done on? Nadolol. Okay? Non-selective beta blocker. All right, so now kind of clinical correlate. How do they work? Who knows? How do they work? How do these beta blockers work to reduce the risk of bleeding? Very effective. It's one of the most effective things we do in cirrhotics. Put them on beta blockers, right? How do they do it? What do they do? The beta blockers, they don't vasoconstrict. They vasodilate, right? What do beta blockers do to your blood pressure? Right? They lower it. How do they lower it? They vasodilate. Okay? So what do? They lower portal hypertension. Very good. Okay? Everybody okay with that? All right. Let's say this again. How are you going to manage if this guy had ascites? What are you going to do about his ascites? You're going to tap, right? And what do you do after that? How do you treat it? We don't prophylax. I see what you're saying. If he had endoscopy, yes. If you prophylax with antibiotics, we'll talk about that a little bit later. We give him diuretics, low salt, spironolactone, furosemide, right? And we always do paracentesis. This guy didn't have it. Okay? Everybody okay with that? Watch people with varices, right? These patients have severe bleeding. They have to be stabilized. They have to be put in the ICU. Eventually, when the patient stabilizes, they have to be put on non-selective beta blockers. Okay? Be careful. That's right. So Ella says, what do we do every year? We follow them up with an endoscopy. All right? Because if there's more varices, you ban them. All right? Now look at this. Somebody who is a cirrhotic and you've put on propranolol comes in with an upper GI bleed. What do you do to the beta blocker when they come in with an upper GI bleed? You stop it. So, all right, now you were trying to avoid bleeding. They got it. Done. You got to take them off the beta blocker. If you keep them on the beta blocker, what's going to happen? They're going to get worse. They're going to get more hypotensive, right? All right, so watch it. Use common sense a little bit. If they get a GI bleed, you got to stop it. But what's the best treatment to reduce the risk of bleeding for varices? That's a non-selective beta blocker. Okay? Everybody okay with that? All right, very good. Let's take a 10-minute break and we'll come back and talk more about GI. See, GI is, you know, uh, interesting stuff. Okay? Yes. So Rangshi said, is octreotide used in active bleeding? Yes. Octreotide, vasopressin, it's active bleeding. If this patient had active bleeding, right, we would use that. You probably don't need to use it right now. Okay? All right. See everybody back here in 10 minutes. All right, everybody, we're back here. We got to do a couple more cases of gastroenterology, but before we talk about the new cases, a couple questions for you all. If a patient has an upper GI bleed, what's the first thing to do? Stabilize, right? Get the vitals and stabilize the vitals, right? Okay, very good. After you stabilize them and all that business, and let's say you want to move them out of the emergency department, where do you want to send them? The ICU. You're going to watch this guy 24, 48 hours, right? In the ICU, usually 24, unless they have some kind of severe bleed. Everybody okay with that? That's all upper GI bleeds and lower GI bleeds. Okay, very good. What is the most important test in the evaluation of ascites? The most important test in the evaluation of ascites. Ascites, paracentesis. Very good. Okay? What is the most important test in the evaluation of an upper GI bleed? See, they got to use this kind of endoscopy, David says. Very good, because you got to figure out, like, okay, is it just a Mallory Weiss tear and you don't have to worry about anything? Or is it varices and this guy's got, a severe bleed? Remember, with variceal bleeds, the mortality is 50%. 50%. 1 out of 2 patients that come to the hospital with significant variceal bleeding never go home. Anybody know what the mortality is on heart attacks in this country? Can you guess? Ed says 5. Oh my God, 30%. No, no. It's way, Naveen says 2%. That's what it is, about 2 to 3%. See, that was 30, 40%, like 50 years ago. Yeah, 2 to 3%. It's less than 5%. So the reason I'm saying this is because I told you guys like this, that people with variceal bleeding have 50% mortality, right? Think about that. I mean, everybody gets bent out of shape, about an MI and, ST elevation MI and all that business. But like when the varices come in, no big deal. I mean, these guys is very, very critical. Okay? Everybody okay with that? So thyroid storm is 50 to 60%. Thyroid storm, very high mortality. All right? Okay, very good. Okay, so this guy says, my gut hurts and I feel better after I eat. All right, wonderful. And you say, wonderful. Okay, 52-year-old man with epigastric pain, right? Wakes him up from his sleep, eating and antacids delirium. So Euclid said duodenal ulcer. That's what I want to hear. So no significant weight loss, okay? No nausea or vomiting. No history of pancreatic or ulcer disease. Does not drink alcohol. Occasionally smokes. Takes aspirin for back pain. All right? What do you guys think? Even before we do the physical examination, what do you think? All right, Edna says duodenal ulcer. See, remember, because duodenal ulcer or duodenitis, right? But duodenal disease, what's the typical? They come on, right? And then they get better after food. They also get relieved with what? With antacids, proton pump inhibitors, and stuff like that, right? Do they have the so-called alarm symptoms? What are the alarm symptoms? Weight loss, early satiety, nausea and vomiting with food. No, they don't. Right? So you can make a clinical diagnosis here. All right? That's cancer. Yeah. That's cancer. It's also what? What's weight loss and nausea and vomiting with food? It could be cancer, or what else? What's the other one? What's the other one, Alfred? So stomach ulcer, right? Stomach ulcers do this. Gastric ulcers, you don't feel better when you eat. So what do? You stop eating, so you lose weight, right? All right, very important. Okay, so this guy is healthy appearing, in mild distress, vital signs stable, heart, lungs normal, abdomen normal, rectal exam, hemoccult negative. All right, so what do you guys think? So what's the likely diagnosis? It's likely, and then we'll kind of generate a differential. So duodenal ulcer, right, would be on the top of my list. All right, so you got to be more specific than peptic ulcer, because peptic ulcer, is everything. Peptic ulcer is gastric ulcer, duodenal ulcer, gastritis, duodenitis, erosive gastritis, all that business. So you want to be more specific. Not likely esophagitis. How does esophagitis present? So, I would have it on my list, but this would be lower, right? So, dysphagia, right? So, chest discomfort, burning sensation, stuff like that, right? So, we don't hear anything like that, but maybe, okay? So, on the top of my list would be number one here would be duodenal ulcer, gastric ulcer, right? Remember, gastric ulcer presents with pain when you eat food. So what happens? You have vomiting and pain with food and stuff like that. And what do? You stop eating. So you lose weight, right? You lose weight. So they kind of look like stomach cancers in a way. That's why I see gastric ulcer clinically, you can't tell the difference between that and cancer. So you kind of treat them the same way. Kind of have to go down and take a look. Esophagitis. You guys said esophagitis, so I'll take that. Even though it doesn't sound exactly like it, it's a very common disease and it can present in many ways. Gastric cancer, unlikely. We don't hear early satiety and stuff like that. Cholelithiasis, right? This pain usually occurs after you eat, right? It's usually on the right side. It may be epigastric, but less likely. So number one would still be a duodenal ulcer, right? Everybody okay with that? Now, everybody remember what's this patient's age? Because age plays a role with this. 52. So all right, over 45. Over 45, 50. So they're a little bit, high in age. But so the bottom line is, look, if the patient's over 45, 50, usually you do an upper endoscopy. If the patient is 20, 30 years old, you say, okay, this sounds like a duodenal ulcer. Let me make a clinical diagnosis. And Eric says, give him a proton pump inhibitor, right? Give him a proton pump inhibitor and see if it goes away, right? So, but in this patient, older than 45, 50, some literature says 50, some people say 45, right? This patient will need an endoscopy. If you say, I'm going to treat the patient clinically, okay, and they fail, right, treatment, you have to scope those patients too. Okay? So this patient would likely get an upper endoscopy. Now let me ask you guys this. So what's the association with duodenal ulcer? What's the big association? H. pylori. So remember, the highest association of H. pylori is with duodenal ulcer. So in some literature, 90% of patients with duodenal ulcers have H. pylori. So I got to figure out if this patient has H. pylori, right? Because they're not only going to get a proton pump inhibitor, they're going to get what? They get treatment of H. pylori. They get antibiotics, because studies done 30 years ago showed that if you treat them with antibiotics and you eradicate H. pylori, the chance of recurrent ulcer now is 15% versus 85% of recurrence. Right? Very important. The ulcer clears and it doesn't recur. Okay? Everybody okay with that? All right. So when you do an endoscopy, right? You could do a test for H. pylori on the spot. Anybody know what that test is called? Where the endoscopist, puts a little, this green thing and it turns, a certain color and stuff like that. Good. Rosemary says it's called the Clot test. Remember, you don't do the urea breath test because you're going to do a biopsy on the ulcer anyway. You do this thing called the Clot test. The Clot test stands for Campylobacter-like organism test. It's a modification of the breath test. See, the breath test is an outpatient test. The Clot test is the same thing on a biopsy specimen, right? So when you do the biopsy, if you're thinking H. pylori, you do the Clot test. If you make a clinical diagnosis on this guy, you don't scope them, you don't do endoscopy, then you do what? Now you do the urea breath test, right? Everybody okay with that? Anybody know other tests you could do for H. pylori? What are some other tests? The stool antigen, very good. Okay, and how about blood serology? How about blood serum serology, right? Serum antibodies, very good. So those are other tests you could do. There's three tests you could do for H. pylori, but if you do the endoscopy, right, you have to do the Clot test because it makes sense. That's the easiest thing to do. Okay? All right. So you're in the outpatient setting. They got, tests to make sure this patient didn't have pancreatitis. They even got an ultrasound, right, of the gallbladder to make sure that this patient didn't have cholelithiasis. The liver test and the CBC were all normal, right? Right. So, and then we said this patient, we go straight and we do an endoscopy, right? Always when you do an endoscopy is with a biopsy. So this patient had a 1 centimeter ulceration in the duodenum, no bleeding, and the biopsy, right, and stain is positive for H. pylori. Okay? Everybody okay with that? And Rosemary asked a very interesting question. Do we test for response to therapy? Let's treat this guy first and then we'll talk about that. Okay? So what do we do now in this guy? What's the treatment? Proton pump inhibitors plus antibiotics. All right, give me some antibiotics now. Okay, metronidazole, amoxicillin, clarithromycin. All right, all those work. Some people will use all three of them at the same time. The optimal treatment for H. pylori hasn't been established, believe it or not. Right? So, but clarithromycin, amoxicillin, metronidazole, bismuth salts, very good. Right? Yeah. So they add bismuth salts to it. Works. You could use other stuff too, like tetracyclines, fluoroquinolones, right? But those are the typical ones. 2 weeks of antibiotics. Everybody understand that? Nothing, no sucralfate. Okay, sucralfate hasn't been established. All right, so most people will continue the proton pump inhibitors for a total of 2 months just to heal the mucosa. 2 weeks of antibiotics, 2 months of proton pump inhibitors. Okay, so now here's the right a very important question you guys had, right? So what do we do to check for eradication? Right? So the answer is, first of all, do we have to do it? And the answer is not for everybody. If the patient doesn't have any symptoms, you don't do it. You don't do it. If the patient comes back to you, guys, we did the endoscopy already. Hold on. Let's focus here. Let's focus. We did endoscopy already. We documented a peptic ulcer. All right, we said treatment of antibiotics plus proton pump inhibitors. Antibiotics for 2 weeks, proton pump inhibitors for total 2 months. Everybody understand that? So now the question is, do we have to show eradication? The answer is no. But you do a follow-up with the patient a couple of months later, and you make sure that the pain has gone away and his symptoms have gone away. If the patient has some symptoms, then you have to do a test to show eradication. Because some of the H. pylori are resistant. Or what somebody asked is, they go back into the community, and what happens? You get infected. You get infected, so you get H. pylori again. You get reinfected. So if I wanted to test, so let me give you an example. So I had this guy in his 60s, and we did an endoscopy about a year and a half ago, and he did fine. He had a peptic ulcer. We treated it with antibiotics and a PPI, and he comes back to me a year later, and now says, I have a little bit of the pain again. So now I want to check, did I eradicate it? Did he get reinfected? Good. So the Euclid's got the answer. So the answer is, what test do I do? And the answer is, Rosemary's got the answer. So it's either stool antigen, right, or the urea breath test, right? Because you may have to retreat. Okay? Everybody okay with that? So how did he get reinfected? How did he get reinfected? So this is a good question. The environment, right? The wife, the husband, the food, it's very, it's in the environment, close contacts. Very good. If this patient had H. pylori a year and a half ago, would I be able to show eradication by checking H. pylori antibodies again? That doesn't make sense, right? If we check antibodies again, then we don't understand what it means. Guys, it's not time. Serology is positive when you diagnosed them a year and a half ago. It's going to be still positive a year and a half later. All right, maybe the IgM is not positive, but who cares? You're not going to be able to tell if this guy's been reinfected unless you do the stool antigen. It's an antigen or the urea breath test. Serology, once it's positive, it's always positive. Right? Everybody okay with that? Okay, anybody know what percent of the population is H. pylori positive? It actually depends where you are in the world. It's sometimes even higher. Yeah, some places, H. pylori could be like 3/4 of the population. That's right. It depends on the economy. It's very interesting. That's right. So it's out there, right? So why doesn't everybody get peptic ulcer disease? That's the question. Why doesn't 75% of the population get? So not only do you have to have, I don't know one, but if it's 90, but I've been to places, I've lived actually abroad, it's like 60, 70%. So there's got to be other risk factors, right? So there's got to be some genetics involved. So it's interesting. You see the people in one family, right? Everybody has H. pylori. Only one guy in the family gets peptic ulcer disease, right? So it's other factors. Genetic, smoking, alcohol, right? Everybody okay with that? So there's no way to rule out resistance. You just treat it with triple therapy, right? And if the patient has symptoms, you go back and you repeat the urea test to make sure you eradicate it. Okay? Everybody okay with that? Now let me ask you this. Do we check for H. pylori? So one of the students one time in the DC center, she came and told me that, um, you know, so she came and told me that her primary care physician checks H. pylori on her every year. What do you guys think? No, it makes no sense because you're not going to treat it, right? Unless the patient has symptoms. If we treated everybody, we would have resistant H. pylori. But right, maybe they're billing every year. There you go. I thought about the same thing. I don't know. It didn't make sense to me, right? Everybody okay with that? All right. What if I didn't find H. pylori positive here? All right, let's scratch this out. Okay, Giuseppe asked a good question here. All right, so I'm going to ask you two questions. What do we do in this case? If we find the same findings on the endoscopy, but no H. pylori, so you just use the PPI. Very good. So listen, this is not, you shouldn't be thinking Zollinger-Ellison syndrome. It's a small ulcer. This guy doesn't have resistant peptic ulcer disease. Just use the proton pump inhibitor. 2 months, right? Remember we said 2 months, right? Everybody okay with that? All right. If a patient has a duodenal ulcer and it's not from H. pylori, so the H. pylori is negative, what is the second most common cause? The second most common cause of peptic ulcer disease. You guys know it, NSAIDs. So I asked this guy, you taking NSAIDs? He says, no. So what do you ask him? Are you taking any over-the-counter pain meds? And he says, oh yeah, of course, I take it for my arthritis. Right? He's taking indomethacin or something like that. Okay? Advil. All right? Everybody okay with that? So look for that because sometimes they don't give it to you in the history. Okay? All right, very good. All right, let's go a little bit further down. Okay, so look at here. This is a big clinical pearl. All right? So look at this. H. pylori is associated with all forms of peptic ulcer disease except Zollinger-Ellison. So gastritis, duodenitis, gastric ulcer, peptic ulcer. It's associated with cancer of the stomach. Okay? It's associated with maltoma. What's maltoma? Good, Yvonne. Hey, maltoma. What's maltoma? That's a good question. Very important. Right? It's a lymphoma, lymphoid tissue. So you know what happens when you treat H. pylori? Why it's an important finding? Because it melts away. When you cure H. pylori, it goes away. That's right. Okay, guys, please, that's right. It's called mucosal associated lymphoma or maltoma. Okay, please be careful. It is not associated with reflux disease. Okay, if the patient has reflux and you're checking H. pylori, you got that question wrong. You understand that? You got that question wrong because they're telling you classic reflux disease, you're checking H. pylori. You're not going to treat it. It's not associated. Okay? Non-ulcer dyspepsia is different. I'm talking about classic esophageal reflux disease. Non-ulcer dyspepsia is unclear. It's H. pylori is not associated with that. It's unclear if it is or not. Non-ulcer dyspepsia means you got classic symptoms of peptic ulcer disease, but you don't have any findings on the endoscopy. So Euclid said it's a diagnosis of exclusion. That is correct. Okay? All right, very good. Okay, let's go on to the next case. I want to talk about case 4. This patient is confused, right? No. Habib said, are there any foods that are recommended or not recommended for duodenal ulcers? The answer is no. All those are myths, right? Don't eat this, don't eat that, drink a lot of milk, don't do this. They're all bogus. All that stuff people have been doing for hundreds of years, you know, right. Everybody okay with that? All right, very good. All right, this guy's got confusion. All right, 45-year-old man admitted with upper GI bleed 2 days ago. He's an alcoholic with history of alcoholic liver disease. The endoscopy, on admission found a bleeding duodenal ulcer, which responded to omeprazole. Okay? Patient appeared to be stabilizing. This morning, he's increasingly confused. Guys, listen, don't, I, I told you what to do in duodenal ulcers. What did I say you do after you treat the patient? You follow up, right? Oh, hold on. What do you mean I see you? After the duodenal ulcer, you follow up, all right? If they have symptoms, what do you do now? You check for reinfection. How do we check for reinfection? With stool or the urea test? Did I say you do an upper endoscopy again? All right, you're trying to buy that Ferrari, right? So you're saying to the guy, come back, I need to scope you a couple times more, right? So listen, so so somebody says the student, Euclid, you're going to get rid of the student loans in the first year of post gastroenterology fellowship. Okay, hold on, Forget about Mayweather. Whoever spent money to see that, it has to be crazy. Okay, look, this is important. Duodenal ulcers, you don't have to rescope. The chances of cancer are zero. A gastric ulcer, sometimes if they still have a lot of symptoms, even though the biopsy was negative, some people get worried. So if you find a gastric cancer, maybe it was not really a gastric maybe if it wasn't a gastric ulcer, it was a gastric cancer and you missed the biopsy, right? So sometimes in those patients, if the symptoms get worse or they don't go away, then some people recommend doing a repeat endoscopy only with gastric ulcers that are proven. Okay? Everybody understand that? All right, so let's go back here. So this guy was stabilizing, right? This guy had an upper GI bleed and was stabilizing, right? Found a bleeding duodenal ulcer. So we're talking about this guy now, right here, right? In the morning, all right, confused, agitated, oriented to name but not year. He thought Nixon was president. How about that? What do you guys think? Good. So people said, now look at this. They give you this. He has been on thiamine since admission, right? So is that important? Yeah. So what are the three things we always think about? We think about vernicase. All right. So if he's on thiamine, we probably should be okay. All right. What are the other two things that we think about? Delirium tremens, okay, and hepatic encephalopathy. Okay. How does hepatic encephalopathy present? They're confused, right? They're confused. They're somnolent. They reverse the sleep-wake cycle. How about delirium tremens? Good. Ed says presents just like this case, right? So how about delirium tremens though? Now he's got a lot of autonomic stuff, right? He's got visual, he's got auditory hallucinations, right? He's hypertensive, he's agitated. This is the guy's trying to jump out the window. He's trying to run away. He sees, he's got things crawling under his skin. right? And stuff like that. So that guy's very agitated, right? So look, be careful. This is a clinical diagnosis. You guys are going to have to do this clinically, and you're going to have to do it here on the test. They're going to ask you to differentiate between hepatic encephalopathy and delirium tremens. So let's look at this guy's exam, right? And the vitals. The vitals very important. So Kavitha says more like dementia. Which one? The dementia is more, somnolent and stuff like that. That's the hepatic encephalopathy, right? Because the patients with delirium tremens very agitated, right? Right. So look at this guy. Vitals okay, pulse okay, respiratory rate okay, heart normal, lungs normal, abdomen soft, right? Splenic tip is increased. He's lethargic, uncooperative, withdraws to pain, and is hyperreflexic bilateral. Okay, so this hyperreflexia, lethargic in people with chronic liver disease, you guys should know what this means. Not delirium tremens, right? No ophthalmoplegia, so no Wernicke's, right? So this is probably from what? Probably from hepatic encephalopathy. All right, very good. He's got asterixis is present, but no nystagmus, no ophthalmoplegia. All right, so what does this look like more than anything else? Sarah says hepatic encephalopathy. Very good. All right, so my differential is hepatic encephalopathy, doesn't look like delirium tremens, doesn't look like Wernicke's. Okay, doesn't look like an infection. Everybody okay with that? Now you could get routine tests and you could check ammonia levels, but look at this. How do you make the diagnosis? It is a clinical diagnosis. It is a clinical diagnosis. Everybody remember that? Clinical. All right, now you guys were asking me before, and I was telling you, hold your horses. How do you treat hepatic encephalopathy? All right, now we made the diagnosis. I mean, we'll get some routine tests. Good. Lactulose, very good. How much lactulose? How much lactulose? Lots of it, right? So until, right? So no, so we, all right. See, Suman's getting. You guys are doing what I did to you before, right? She was like, but you don't need to know the dose. You don't. But it's very important that you know. I ask you stuff that are clinically important. Imad says you titrate to 2 to 4 stools, right? The nurses, Yvonne, hate your guts. You know what they hate you more? You know what they hate you more about? If the guy's, uncooperative, so you can't give him lactulose by mouth. And so which way do you give him? So if you can't give him by mouth, right? You can't go here, you go there, right? So you give him enema. There you go. So you titrate them to 2 to 4 bowel movements. See, why is that a very important clinical point? See, if this guy doesn't have, bowel movements, you're not going to clear the ammonia, right? And stuff like that. See, I knew you guys would love that, right? Right, so the ammonia flushes out with the diarrhea. Plus, what do you give them? You give them antibiotics like rifamycin, right? So why do you give them antibiotics? They used to give neomycin. Now you give rifamycin. So more expensive. Kill the gut flora. But why do I want to kill the gut flora, Ed? Kill the bacteria, making the ammonia, right? They produce ammonia. So what are the two main treatments of hepatic encephalopathy? Lactulose and antibiotics, right? Everybody okay with that? All right. Let me ask you guys this. Why did this, good. So there's other antibiotics. Remember I said rifaximin, neomycin, other antibiotics. So there's not, I just stated a couple of them, right? There's other antibiotics, okay? So why did this patient get hepatic encephalopathy now? Why now? The bleed. All right, tell me about the bleed. Well, why did he get now? GI bleed. Protein, Heider says. That's the answer. Okay, tell me some other condition. No, they told us he bled. He told us he bled, so that's for sure. Okay, digestion of the proteins. Okay, all right. So tell me other things that precipitate hepatic encephalopathy. So Euclid said dehydration. That's number two. Infection. Number three. Hypoxia. Okay, the other one I wanted to see is overdiuresis. Okay, with hepatorenal syndrome. Those are the five. Okay, all right. So I'm glad somebody said medication, sedatives. So let me ask you guys this. So we talked about the five main things that precipitate hepatic encephalopathy: GI bleed, infection, dehydration, right? Overdiuresis, that's dehydration, right? And hepatorenal syndrome. That's again like dehydration. Okay? But one of the most important things is medication. So what's the treatment of delirium tremens? What's the treatment of delirium tremens? So benzodiazepines, right? Alcohol. Oh my God. No, you can't give alcohol. You can't find it in American hospitals anymore. The good old days, you used to give them a bottle of alcohol and everything went well, right? So no, you have to give them benzodiazepine. So what's the point I'm making? If you miss that, so if you misdiagnose, if you misdiagnose encephalopathy for delirium tremens, and you give them benzodiazepines or alprazolam, diazepam, or any one of those, what are you going to do to this patient? Make them worse. So many of our residents in this country have done that without, wanting to do it. All right, so be careful. That's why they want you to make a clinical diagnosis. Okay? All right. So let me show you a couple of the labs and then we'll go to the next case. So they're thinking about hepatic encephalopathy. They're thinking about alcohol withdrawal. Look at the labs, right? There's nothing in the labs here. Okay, fine. This guy's got a low hemoglobin and the BUN creatinine is okay, right? And the AST, ALT is a little bit elevated. LDH is okay. But none of this confirms hepatic encephalopathy or delirium tremens, right? Now look at this. They got ammonia levels and it was elevated. All right, so let me tell you a little bit about this. This is very important. The ammonia levels, elevated ammonia levels, are consistent with hepatic encephalopathy. In order to do this test correctly, anybody know what you have to do? You have to do it right away. In order for this to be sensitive and specific, you have to draw the blood, put it on ice, go downstairs to your lab, right, and run it. Okay? Does anybody do that on call? Anybody do that? It's hard to do that, right? You're gonna get, somebody to do it for you, right? All right, so be careful because this is not a great test. Okay, you could get it and check for it, but I'm telling you, that's not the test. The test is a clinical diagnosis. Okay? Everybody okay with that? They're going to ask hepatic encephalopathy. They're going to ask it. You have to differentiate it from Wernicke's and delirium tremens. Right? Hepatic encephalopathy, lactulose, antibiotics. Delirium tremens, benzodiazepines, benzodiazepines, benzodiazepines. Okay? Be careful about delirium tremens in somebody that doesn't tell you about alcohol use. So somebody gets put into the hospital for elective surgery. She or he is a pillar of society where you live, and they wake you up in the middle of the night because she's seeing little green men run around in her room and all that business. She's got delirium tremens. Okay? Do you ask her about drinking? She says no. She's got delirium tremens. Okay? Treat it aggressively because that has high mortality, up to 10%. I don't know, but I got to tell you, one time I walked into this room, you know, um, the ammonia levels are unstable. right? So this is not a good test unless you run it right away. See, if you leave somebody's blood out for a couple of hours until the tech comes and picks it up, the ammonia levels go up whether this guy's got liver disease or not. That's why you have to run it right away. Okay, Wernicke's encephalopathy is also a clinical diagnosis, right? Now you got ophthalmoplegia, right? What else do they have? They have confusion. What's the third component? Ataxia. Okay, very good. All right, very good. All right, let's do just a little bit of one more case, and then we'll take a break. All right. So the chief complaint is diarrhea and abdominal distension and weight loss. All right, so look at this. When you hear diarrhea and you hear weight loss, so right away it tells you that this is probably not one of the benign causes of diarrhea, right? It's not acute, right? And it's probably not benign. What are some of the benign causes of chronic diarrhea? Some people, a lot of people, benign causes, irritable bowel syndrome, yes. Celiac disease, not benign. Lactose intolerance, so that's what I was looking for. Guys, malabsorption syndromes are not benign, right? People get, vitamin deficiencies, they get cancers. Benign is like lactose intolerance, irritable bowel syndrome. That's a benign. Okay, so when I see this weight loss business, I always worry, right, that this is serious. Okay, so let's look at this patient. A 27-year-old woman comes to your office with 8 months of diarrhea, weight loss, and a pruritic skin rash. No blood in the mucus in the diarrhea. I'm sorry, no blood or mucus in the diarrhea. She's very anxious. She feels recently depressed. She's frustrated. She cannot identify the cause of the diarrhea. She's obsessive about eating only food that cannot be contaminated. No fever, abdominal pain, bleeding, appetite is excellent. Right? So what do you guys think about that? Something's up, right? When I hear about pruritic skin rash, right? Pruritic skin rash, think about things like celiac disease, maybe inflammatory bowel disease. Okay. Temperature, okay. Blood pressure, okay. Pulse, okay. Respiratory rate, okay. Ears, eyes, ears, nose, and throat, and neck is okay. Abdomen, soft, not tender, somewhat distended, hyperactive bowel sounds. Rectal exam shows hemoccult negative stool. She's got a diffuse papulovesicular rash over the elbows and the knees. So this kind of like, coalesce. So they call this a herpetiformis, dermatitis herpetiformis, or herpetiform rash, right? Now you're worried that this patient has what? Not just any diarrheal syndrome. This is consistent, right, with celiac disease. You still got a long way to go. Inflammatory bowel disease causes erythema nodosa, right? Causes some other rashes, but not this herpetiformis-like rash, right? But that's why we said inflammatory bowel disease. So, but you have to think about inflammatory bowel disease, right? You definitely have to think about celiac sprue. Okay, look at this. Lactose intolerance doesn't cause a rash and doesn't cause weight loss. All right, be careful. These are benign causes. Irritable bowel syndrome, same thing. What's Whipple's disease? Trephorema Whippley. Trephorema Whippley. It's an infection of what? Trephorema Whippley. Of the small bowel. So if you have your small bowel infected, what happens? Your small bowel is infected, right? So it gets all destroyed. So what do you have? Now you have a malabsorption. It's like having celiac disease, right? So what do patients with Whipple's disease have? So they have the diarrhea, they have joint problem, right? And they have CNS disease. They typically don't have rashes. I mean, the typical cases don't have rashes. Okay? So yeah, the other one is tropical sprue, but we don't have any history that this patient has lived in the tropics. Right? So usually tropical sprue is like celiac sprue, right? But people that have lived in the tropics. Right? Right. Okay. Here you go. You want celiac disease on top? All right. I'll put celiac disease here so you guys could feel better. There you go. Celiac disease. There you go. Kavita's right. Okay. Now you feel good. Beautiful. It should be on top. Okay? Everybody okay? All right. Now we don't want anybody to relax, right? This is good stuff. All right. So tell me some tests to get in this person, and then we'll take a break. We'll come back with the results. All right. Ryan says go for the money. Antigliadin, right? Anti-endomysial antibodies, anti-transglutaminase antibodies, stool culture. All right. Go biopsy. All right. Go for the small bowel biopsy right away. You need that Ferrari, right? Colonoscopy up and down and right. So listen, don't do too much stuff. Get the stool studies, get the CBC, because you may have an answer with some of this, right? Stool studies, CBC, look for vitamin deficiencies, right? Transglutaminase antibodies, anti-endomysial. Okay, good, very good. Somebody said D-xylose, lipase, because you're looking for maybe pancreatitis, right? Okay, let me ask you guys this, and then we'll take a break. What's a D-xylose? Remember the stool studies you do the Sudan stain, stuff like that. What's a D that they don't do a lot of this now. You may see it in some specialty hospitals. D-xylose. Right, doesn't need anything. It's just a sugar, right? And it gets absorbed as long as you have a small bowel surface. If you have a small bowel surface, you absorb it. What do? You don't do anything to it. You excrete it in the urine. So if I give D-xylose, I measure it in the urine, what does that mean? That the small bowel is intact, right? Okay, so then what's the problem with your diarrhea then? If your small bowel is intact? All right, it's pancreatic problem. If it's not the small bowel, it's pancreatic. So you're talking about malabsorption syndromes now. So the D-xylose sometimes allows us to differentiate in confusing patients the difference between small bowel malabsorption and pancreatic insufficiency. Remember the two big groups of diseases that cause pancreatic insufficiency. That cause malabsorption is pancreatic insufficiency and small bowel disease. Right? In this patient, we don't have any evidence of that. Okay, so maybe we think about it, right? Maybe we think about pancreatic disease as a, lower. Maybe we want to just rule it out, right? So in adults, what causes pancreatic insufficiency? What are the two main things that cause pancreatic insufficiency? Alcohol, right? So if you have multiple bouts of acute pancreatitis, eventually causes chronic. No, that's stones cause acute pancreatitis. Hypertriglyceridemia causes acute pancreatitis. HCTZ acute, not cancer. What causes a disease where the pancreas gets chronic inflammation? Massar said cystic fibrosis. That's it. So the two diseases are alcohol and cystic fibrosis, right? Those are two. Those cause chronic pancreatitis. Chronic pancreatitis. Okay? All right. Let me stop there. Let's take a 10-minute break and come back and we'll do more of this and talk about this. All right, I'll see you back here in 10 minutes. 10 minutes. Let's put the good. Thank you. All right, everybody, we're back. So I had a couple questions for you all. So, what's acute pancreatitis? That's inflammation, and the patient presents typically with abdominal pain. Chronic pancreatitis is now your pancreas is all scarred down, right? Fibrosed and scarred. The patients have abdominal pain again, but now you got loss of function, right? And this patient now doesn't have pancreatic enzymes, may have less severe pain, right? But what happens? They present with a malabsorption syndrome, right? This is a severe form of malabsorption. If you don't have pancreatic enzymes, you develop a severe form of diarrhea and malabsorption. What did we say are the two main categories that cause malabsorption? The two main categories of diseases. I said two broad categories, small bowel and pancreas, right? Small bowel disease and pancreas. Think broad categories so then you remember differential diagnosis. What causes small bowel disease? Celiac. All right, what else? Whipples. Okay, what else? Tropical sprue. All right, proximal Crohn's disease. You got it. Okay, what causes pancreatic insufficiency? Cystic fibrosis. Guys, I remember stone causes acute pancreatitis. It's alcohol and cystic fibrosis. Drugs, triglycerides, stones, they cause acute pancreatitis. Right? Everybody okay with that? Right? We have to remember causes of malabsorption. Very important. Okay, very good. So these guys got a CBC. They look for vitamin deficiencies by getting B12, calcium levels, folate. They got iron studies also. They looked at stool cultures, make sure they didn't have ovarian parasites. They took a look in the stool for fecal leukocytes. So what causes the fecal leukocytes to be positive? Infection or inflammation, right? So what causes inflammation? Infection or inflammatory bowel disease. Very good. Okay. We looked at the fat in the stool with the Sudan stain, right? So you do the Sudan stain to see if the patient has fat malabsorption. You could even send the stool away for 24 or 48 hour of evaluation for fat. And they even went further and did the D-xylose test. Remember the D-xylose test? When is the D-xylose test abnormal? Abnormal. Bowel disease. Remember? Abnormal means that you can't absorb D-xylose. What did I say? You need to absorb D-xylose. Only a normal bowel. You don't need any enzymes. You don't need anything. You need an intact bowel. Everybody okay with that? That's when it's abnormal, when I don't have an intact bowel. All right, so let's look at these tests a little bit. All right, so, sorry about that. So this patient has a mild macrocytic anemia. B12, folate, serum iron, calcium, magnesium are all mildly decreased. Stool culture is negative for enteric pathogens. The stool exam is negative. The smear is negative for fecal leukocytes. This patient has fat in the stool, right? And the D-xylose test is abnormal. Okay? What do you guys think about that now? Multiple vitamin deficiencies, D-xylose abnormal, fat in the stool. Small bowel. So now you're thinking even more about celiac. All right. So tell me what to do further down now. How do I confirm celiac? What are adjunct studies I get, etc., etc. So I go for the small bowel biopsy. I get antibodies because this is an antibody disease. What's a what's the important antibodies? Antigliadin are the older antibodies. The important ones are transglutaminase and endomysial antibodies. So what is celiac sprue? What's celiac sprue? Gluten enteropathy. It's like an allergy to gluten. What foods have gluten? What are the typical foods? Pasta, wheat. All right, so you can't eat pizza, you can't eat pasta, right? None of that. You tell that to a little kid, right? So what is it associated with? Yeah, and you guys can't even drink vodka. That's a bad one, right? So diarrhea, lymphoma, right? The skin rash, dermatitis herpetiformis, multiple vitamin deficiencies, right? Very good. Okay, wonderful. So we talked about this. All right, so further management, anti-endomysial, anti-transglutaminase, anti-gliadin antibodies are all positive. The small bowel biopsy is abnormal with total villus atrophy. All right, so they get this cracked mud look, because there's so much atrophy. Okay, so the biopsy, Juan, not only to look for lymphoma, but the biopsy is what documents celiac sprue, right? Because some people, they even repeat the biopsy. Biopsy is mandatory here. So what do you do after you find a biopsy that looks like celiac sprue? Because it looks like it. It's not. Nothing is pathognomonic here, right? You treat. So what's the treatment here? Stop gluten. All right, very good. Avoid gluten. Avoid gluten forever, right? And then what do? Some people, just to make sure, they go back 3 to 4 months later, and what do? They repeat a biopsy. And not so much serology. They go in and confirm a biopsy. What do they see on the biopsy? Now, right, it's reversed. Now it looks pretty normal. Now, the lymphoma is a complication way down the line, right? You don't see lymphoma early. That's a long-term complication of celiac disease. You see normalization 2 to 4 months later. Now you're pretty much confident in the diagnosis, right? Everybody okay with that? So listen, be careful because you gotta confirm celiac disease. You can't, kind of say, look, just remove gluten and people feel better. This is like the West Coast, everybody's eating gluten-free diets, and everybody says, I feel better, so I probably have gluten enteropathy. It can't be that 80% of, Los Angeles, have celiac disease, right? All my friends that moved to California, now they're gluten-free, right? They tell me that they have celiac disease. I doubt it. Okay? But yes, people that have documented celiac disease, you have to keep them off gluten forever, right? So you do the first biopsy, you see flattening of the villi. You take gluten off the diet, and you come back, right? And you come back 2 to 4 months later, you repeat biopsy and see normalization. Right? Too much Dr. Oz, definitely. He's a good guy, but now, all the doctors think he's crazy. In Colombia, they're trying to get him off the out of the hospital. They're trying to take away his appointment at Columbia University. Oh, but the dean there, Lee Goldman, said, well, I don't think he means it and stuff like that. There's people that, they think Dr. Oz is the Bible. Yeah. So anyway, so some of the faculty there got pissed off at him. Yeah. Okay. So everybody okay with celiac sprue? There's going to be some question about celiac sprue. Be careful because even though this is a pediatric disease, there's documented cases now in early adulthood, even in adult age. So we diagnosed one case that was 62 years of age. First time diagnosis, documented celiac disease. So this disease comes in kind of waves sometimes. Okay? All right, very good. Celiac disease. So remember, very good. Oh, we have to know. Okay, we have to know this. Anti-tissue transglutaminase antibody, the IgA, is the most sensitive and specific test. Okay, if somebody has IgA deficiency, of course you can't tell if they have this, because it's low. Okay? So you can't measure it in IgA deficiency. So they actually, when they measure this, they also measure IgA because a lot of people in the population have IgA deficiency. Okay, very good. All right, so we talked about all this stuff. All right, the last thing we have to know here is the T cell lymphoma. All right, so you guys mentioned this. It's about 10 to 15% of the cases. So it doesn't happen to everybody, but you tell people, look, this is one of the reasons why to stop eating gluten because we don't know, it's unclear, but it may be associated with eating more gluten. People that are cheating all the time and stuff like that. Little kids. They don't like to be with the other little kids and not eat pizza, don't eat pasta and stuff like that. So you have to make a concerted effort. Talk to the family. It's very important, right? So everybody off gluten. Makes the little kids more adherent. Okay. Usually 2 to 4 months after we remove gluten, right? We go back and we rebiopsy. Okay? Some people do. A lot of people do. Okay? So adenocarcinoma, right, is another cancer that celiac sprue is associated with. Okay? So T cell lymphoma and adenocarcinoma of the intestine. All right, very good. Left-sided abdominal pain. All right, let's see what you guys think. A 78-year-old woman comes to the office complaining of left-sided abdominal pain for the past 24 hours. She had a similar episode approximately 3 months ago and seemed to go away on its own. Yesterday, she noted abdominal pain on the left lower abdomen. It steadily worsened over the course of the day in association with low-grade fever. All right, so SAR says diverticulitis, right? That's right. So this is, left-sided pain in an older individual in the Western world. It's diverticulitis until proven otherwise. Because remember, we know that if you look in the colon, right, in people in Western societies, this is the kind of like the transverse colon, right? And now the left-sided colon, you find these diverticula in 40% of people. So, if you take 100 people off the street and they're older than 45 years of age, you find 40%, you find diverticula, right? And now these diverticula, most of the time nothing happens, but sometimes they get obstructed here. See? With what? A fecalith. So a fecalith is kind of like a scientific way of saying a hard piece of stew, you know? They get obstructed, right? So Arthur says red meat diet, right? So the question is, why do people in the Western world have such high prevalence of diverticular disease? But if you go to developing countries, maybe it's 10%, 12, you know. Right. So, high fiber diet or lack of high fiber diet in Western society, a lot of protein and stuff like that, right? So, but when this obstructed, branding like this, right? So because now it's infected, it's inflamed, right? And now you got left-sided pain, you got fever, you got leukocytosis, all that business. Now it's called itis. Now it's called diverticulitis. Okay, right? So this is itis. Before it was just diverticular disease. Now it's itis. Okay, everybody okay with that? So so do you guys remember what's the other big complication of diverticular disease? So itis is one of the complications. What's the other one? Perforation, not perforation. Well, this is infection. Perforation is rare. Well, perforation is very rare. So the answer is bleeding. Right. So this is the most common cause of lower GI bleeding in people over 45 years of age. So diverticular bleeding is the most common cause of lower GI bleeding in older individuals. I mean, in terms of coming into the hospital with severe bleeding, right? So the two complications are bleeding and itis, obstruction and infection. So the reason they bleed is because look at here. So as this diverticulum expands, why does it expand? Because you're putting a lot of pressure and moving your stool. So it expands into a vessel here, right? And once it expands into a vessel, it ruptures this vessel, and this guy has a good bowel movement, and then notices he's got about 2 liters of blood in his toilet, right? And this is so these patients actually clinically they have significant lower GI bleeding. It's not like, occult bleeding. These guys have a lot of bleeding. Okay? Everybody okay with that? So it expands into, you know, a vessel. Okay? Bright blood per rectum. Okay? All right, so let's look at the exam and make sure we're thinking right. The patient denies nausea or vomiting. There's no change in bowel habits or blood per rectum. There's no change in urinary habits or weight loss. Her appetite is good. Her temperature is 101, so she's got a low-grade fever. Her blood pressure is okay. Her pulse is a little elevated. Respiratory rate may be a little elevated, but looks okay. Heart and lung exam is normal. The abdomen is soft, non-distended, mild rebound noted in the left lower quadrant. So a little bit of rebound. No evidence of peritonitis or CVA angle tenderness. The hemoccult is negative. Okay? All right, so do you guys think we're still in the right diagnosis here? So Massar says itis all the way, right? All right, good idea. Because there's not a lot of other things this could be. So you guys are thinking diverticulitis, all right? Right, we put this number one now, right? Okay, good, sounds good. Pyelo, less likely. No CVA tenderness, right? Appendicitis is always a consideration, right? But usually starts on the right side and goes to the left sometimes. Yeah, this would be very, very atypical, especially in a 78-year-old, right? But now colon cancer can obstruct. In fact, colon cancer can sometimes present with diverticulitis. Remember I said, so you got, this obstruction here, you know, it's a stool usually, but it can be sometimes colon cancer obstructing the stoma. All right, so that's something to think about. But it would be again diverticulitis. It would be causing diverticulitis. But this is important to remember that sometimes colon cancer could do that because Why? Because you have to always do colonoscopy eventually in diverticulitis. You have to do a colonoscopy to make sure there's no colon cancer there. That's right. After the acute episode, when the patient stabilizes and, is outside the hospital. Okay? So good to get some routine tests, right? What do we want to see from the CBC, right? Usually leukocytosis, biochemistry profile looks pretty normal. Chest x-ray should be normal, right? Abdominal x-ray and urinalysis, all that should be normal. If this is clear cut diverticulitis. So the white count is 15,000. That's definitely notable. Normal hemoglobin. The biochemistry profile is normal. The chest x-ray is normal, right? The abdominal film shows air-filled small bowel in the lower pelvis, but no intestinal obstruction. This is important. No free air, right? Your analysis, no pyuria, so we're pretty much done with pyelo. Okay? All right. So what do you do now? So if you're still unsure, you do a CAT scan, right? If you're pretty confident, you go ahead and treat the patient. Okay? Now, does anybody know why they did a chest x-ray? That's right. That is exactly why, because the best film to look for air under the diaphragm is a chest x-ray. So you look for perforation, right? That's a good question. Free air under the diaphragm. It's more easily seen on the chest x-ray than it is on the abdominal film. Okay? So now you got two possibilities, right? If you're if you're pretty confident, right? If you feel confident that you got the right diagnosis here, you go straight forward and treat the patient. Okay? If you're still have some questions, then you do a CAT scan. This CAT scan is without contrast. See, remember I said, so when you have the diverticulum here, it's all stranded. So you could see this like this, right? Stranding. Everybody okay with that? Okay, very good. So you could see the stranding on the CAT scan. And then if it's positive, right, then you go and treat it. Everybody okay with that? So if you have a perforation, right, of some organ, and that's what's causing the pain, you should see air under the diaphragm. That's what the air under the diaphragm means. It's coming from some kind of closed organ perforation. It could be the stomach, it could be the diverticulum, it could be anything. Okay? So, but back here, this patient doesn't have any of that. And if you had any more questions, right, then you go and you do the CAT scan. All right? Everybody okay with that? What's treatment of diverticulitis? So what bugs cause diverticulitis? Gram-negative, E. coli, Klebsiella, maybe some anaerobes. Good. Okay. So remember, same bugs that cause SBP cause diverticulitis, cause urinary tract infections, bladder disease, right? Ascending cholangitis, right? And stuff like that. Same bugs. Gram-negative, anaerobes. So in UTIs, there's no anaerobes, but there's gram-negative. Okay, so that's why the treatment here would be what? Things like ciprofloxacin and metronidazole, ceftriaxone and metronidazole, ceftriaxone and ciprofloxacin, right, to cover gram-negative and anaerobes. What else does the patient need? IV fluids. Nothing by mouth. You want to rest the bowel. So antibiotics, rest, IV fluids. Usually the patient gets better. In older patients with comorbidities, we usually admit them to the hospital and watch them a couple of days, then switch them over to oral stuff, and then send them home for 2 weeks of antibiotics total. For younger patients with diverticulitis, this disease can sometimes, you'll see them being treated in the outpatient setting. So you could do this guy in the outpatient setting as long as they don't have comorbidities, right? Most people, though, will be in the hospital, usually on a regular ward. If on the CAT scan you see any complications, perforation, abscess, stuff like that, okay, now you got to get the surgeons involved to do drainage, to do surgery. That patient needs surgical evaluation. If they've had recurrent diverticulitis, and they are fairly young, because younger patients will get it again and again, you refer them to surgery, right? Multiple times diverticulitis, or young people with diverticulitis, or both, refer them for surgery. They're going to get it again. Usually after the second time, you think about surgery. Okay? So there's no set number. But after the second time, you're saying like, look, this guy's got it 2 times already. Okay? You start to think about surgery. Everybody okay with that? All right. Let me ask us something about diverticular disease. All right? Remember, the diverticulitis and diverticular bleeding. Those are the 2 side effects, or the complications, I should say, of the disease. Okay? Very good. All right, so in this case, the CAT scan shows localized inflammation, stranding and changes along the sigmoid colon, no evidence of free air or abscess, right? This is what you guys wanted to see, right? Because now you say, okay, fine, I'm okay. I don't need to get the surgeon involved, right, etc., etc. All right, so now you could go one step further, put the patient NPO, right, IV fluids, antibiotics. So here we go, nothing by mouth, hydration, one of these, regimen, ciprofloxacin or metronidazole. Cipro has good anaerobic coverage. I'm sorry, Cipro has good gram-negative coverage. Metronidazole has good anaerobic coverage, right? And then if you use cephalosporin, you could combine that with ciprofloxacin or metronidazole. If the patient doesn't get better, or we said, has one of the complications of diverticular disease, like abscess or perforation, then of course surgical evaluation needs to be done upfront. Okay? Remember, we don't have to do CAT scan on everybody. You can make a clinical diagnosis, but if there's any question, right? If there's any questions, then you do the CAT scan. Okay? It is without contrast. It's without contrast, so you could do it. Right? It's an easy test to do. Everybody okay with that? All right, so now what do we always have to do afterwards? So now this guy's okay, 2 weeks later he's doing well. Where are you going to send him maybe 4 to 6 weeks later? Now he's got to get a colonoscopy. All right? Right. Why is he going to get a colonoscopy? To rule out colon cancer. That's right. Okay? All right, so now they asked you guys 2 questions on this. What's the gold standard test to diagnose diverticulitis? A CT scan, right? All right. What is contraindicated in acute diverticulitis? What is contraindicated? Relative contraindication. A scope. In the acute phase, because look, if you got inflammation here, right? Here's the stranding and stuff like that, right? All the stranding, right? If you put, you know, a colonoscope here and you put pressure, right? You may perforate this patient. All right, so the barium minimus, contraindicated. You want to leave it as, leave it alone. Okay, don't touch it. Everybody okay with that? Okay, very good. All right, I think we got this pattern down. Okay, case 7. So this patient says, I'm having red blood mixed with loose stools. So this patient is a 17-year-old woman who comes to the office because of bright red blood from the rectum and loose stools for the past 2 weeks. The associated rectal bleeding is with diarrhea, 5 to 6 soft loose stools per day, and lower abdominal discomfort. She's got no history of antibiotic use, fever, unusual travel, or joint discomfort. So what's the differential diagnosis of bloody diarrhea? That's what they're really asking you. Not IBS, right? Not irritable bowel syndrome doesn't cause bloody diarrhea. Bloody diarrhea, not blood per rectum. Bloody diarrhea. This is bloody diarrhea. There's only two things that cause bloody diarrhea. So if the inflammatory bowel disease, what's the other one? Invasive gastroenteritis. That's it. So not just any infection, infectious gastroenteritis, invasive gastroenteritis. Anybody know what the most common cause is in this country of invasive gastroenteritis? Campylobacter. That's right. So that's what it is. Not Shigella, Salmonella. That's more common in other places. It's rarer here. Campylobacter is the most common one. So there's four, right? Campylobacter, Shigella, Salmonella, and enteroinvasive E. coli. So basically, when you see somebody with bloody diarrhea, it's one of two things. It's either the first bout of inflammatory bowel disease, or it's an infection, an enteroinvasive diarrheal infection. Now, there's other ones, but I told you the 4 basic ones. Okay? This patient is afebrile. Her vital signs are stable. Her cardiovascular exam is normal. Her abdomen is not distended with normal bowel sounds. There's tenderness on the left lower quadrant. She's got bright red blood in the rectum. Nothing abnormal is palpated. She's got painful, right, tender, coin-sized lesion on the left shed. All right, what do you guys think about that? It's a nodule, right? Some nodules. All right, so maybe she's got erythema nodosum, and this is what? This is inflammatory bowel disease, right? Maybe this is ulcerative colitis. Now, you guys said ulcerative colitis, right? Because that's the one that has 100% colon involvement, right? That's 100%. Crohn's, it's about 40%. All right? All right, very good. So you guys are thinking about infectious enterocolitis or inflammatory bowel disease. Okay, you could put inflammatory bowel disease here first, right? Because this patient may have some skin lesion consistent with IBD, like erythema nodosum. Okay, and then hemorrhoidal bleeding, is one of the most common causes of bleeding, but It doesn't present with diarrhea. So be careful. Unless this patient has two different things at the same time, this is unlikely. I told you, when you have bloody diarrhea, it's one of two things, right? It's infectious enterocolitis, invasive, or inflammatory bowel disease. All right, so tell me some things that we want to do in this patient to get to the bottom of this. All right, sed rate, CBC, stool cultures, maybe, so you just don't miss infectious stuff, right? All right, very good. ANCA, all right. So examine stool culture, right? All right, that's good. Examine stool for ovum parasite, fecal leukocytes. Now, be careful because, people always get the fecal leukocytes, but fecal leukocytes here will be positive in both inflammatory bowel disease and with infectious enteroinvasive disease. So it's not very helpful here if it's positive. The abdominal x-ray is always good to look at, right? But I'm not sure you're going to be able to diagnose to look for complications, but not to diagnose the difference between these two. And a CBC and a SED rate is important. The SED rate here, believe it or not, even though it's a very, common test and it's non-specific, it's very important because SED rate, the erythrocyte sedimentation rate is elevated because all these reactants, these inflammatory reactants, are secreted by the liver. So if you have an elevated SED rate, you know that this patient, whatever they've had it for some time. It's not like an infection, that's going on for a couple of weeks. The C-reactive protein is even better than the erythrocyte sedimentation rate. So whatever one you choose like that, that's a good test. Because see, if that's normal, if that test is normal, then it's likely to be an acute infection. If that's elevated, it will likely be a more chronic disease like inflammatory bowel disease. The patient had it before and probably didn't know it. It was subclinical. But these inflammatory, particles are around. A very important test here. So the stool culture comes back and it's negative. The ovum parasite is negative. The fecal leukocytes are positive, but be careful, right? This doesn't tell you. See, this is why the boards sometimes focuses on doing tests, but not doing too many tests. Because now you did the fecal leukocytes, it didn't help you. All right, so it's positive in both infectious and in inflammatory bowel disease. So it doesn't help us here. So that's a useless test. The X-rate's normal, so all right, no perforation or anything like that. And the SED rate is elevated. The SED rate is important here, right? That it's elevated because it tells us that this patient has had the disease for some time, right? Now you take this one step further, right? So we said the clinical pearl here, right, is bloody diarrhea in a young patient, usually presents enteroinvasive Campylobacter or the first bout of inflammatory bowel disease. You're going to take it one step further and do a colonoscopy, right? You got to, when you're thinking about inflammatory bowel disease and the cultures come back negative, right? You have to be careful because you have to document inflammatory bowel disease. You can't, you can't say, look, my ANCA's positive in this patient, and this guy's got inflammatory bowel disease, or the fungal antibodies are positive, right? You have to have a tissue diagnosis. You're going to tell this person to get surveillance lifelong and stuff like that. So you need a tissue diagnosis. Okay? So this patient has continuous petechial hemorrhage. It has mild exudates. There's edema, hyperemia that are seen on the rectosigmoid. and it's extending in a continuous manner in the sigmoid flexure. A few superficial ulcerations are noted. So what is this most consistent? When you have superficial, non-transmural, they don't tell us about granulomas. They tell us that this is continuous, right? This is ulcerative colitis, right? So ulcerative colitis is continuous, no skip lesions, superficial disease, no granulomas, no fistula formation. That's UC. What percent of these patients have rectal involvement? The answer is 100%. Okay? Now, so Crohn's has, right, skip lesions, transmural, granulomas, right, and stuff like that. Right? So we don't see anything like that. So hopefully we're right that this patient has, right, ulcerative colitis. Okay? Now, listen. When you start off looking at this patient, you don't know if they have Crohn's disease or UC. So most people prefer going and getting a full colonoscopy. So if it comes back that this patient, remember, because you biopsied this and came back 2 weeks later, if the biopsy comes back and it's Crohn's disease, you have to look at the whole colon, right? I don't know if you have to do an EGD unless the patient has symptoms, but you have to look at the full colon with a colonoscopy. So you might as well get it out of the way from the get-go. Now, the truth is, if you knew this patient had UC, but you don't know that, you could have done only the flex sigmoidoscopy because patients with ulcerative colitis have continuous disease, right? So if you could see half of the colon, and if you see that it's mostly in the rectal area, the rest of the area is free, disease free, you don't need to worry about anything. So sometimes you could get away with the sigmoidoscopy, right? But that's provided only you have localized UC. If you have pancolitis, right, UC pancolitis or Crohn's disease, you have to do a full colonoscopy. So most people say, well, let me just go straight to colonoscopy. Okay, I know if you do a sigmoidoscopy, you don't have to do a prep and all that business, but you know, the most people say, listen, let me just do the gold standard here, get it out of the way. So I don't have to go in and do it again. Okay? Everybody okay with that? Yeah. So in a flare of UC generally, you don't want to go in there, right? But if you know you have UC and you want to do a scope on this patient later, you could do a flex sigmoidoscopy. You don't always have to do a colonoscopy as long as they have limited UC. Limited where? To the rectal area and a little bit beyond that, right? Because remember, a sigmoidoscopy gets half of the way. Okay? Everybody okay with that? All right, let me stop right there. Let's take a 10-minute break and we'll come back and we'll finish all this. We'll talk a little bit more about inflammatory bowel disease and how to treat it. And then we'll do 2 other quick cases and we'll be pretty much done for the night. I'll see you back here in 10 minutes. All right, guys, I'm gonna get started. You guys can't see me. Chris will come back and take the timer off here. Uh, but let me get going. Uh, all right, there we go. All right, everybody. So let me get going. So our last hour, we want to finish up with a couple more cases, and we'll be done for the night. We want to thank everybody for their help, Dr. Mark, Dr. David, Chris, and we'll finish up, and then I'll see you guys in 2 weeks. All right, but before that, let's finish up these last 2.5 cases. So we've diagnosed ulcerative colitis in this patient based on the biopsy. Remember, we always need the biopsy. We need the biopsy or we can't confirm the diagnosis. So the further management is we usually use a combination of sulfa derivatives, things like mesalamine, and corticosteroids. This is the typical drugs that you use for flare of inflammatory bowel disease. So they probably work in both Crohn's and UC. They're probably better in UC because it's an easier disease to control. Eventually, the patient may be put on chronic immune therapy with 6-MP or azathioprine long term. So what you want to do is put them on these types of medications and treat the flares with a combination of mesalamine and corticosteroids. Right? You want to eventually pull them off the corticosteroids. These are young people. So you don't want to keep them on the corticosteroids for a long time. You may want to give them supportive antidiarrheal agents and stuff like that, right? But get them off the corticosteroids eventually. Okay? Everybody okay with that? Generally, if you know this patient has UC, you don't have to do a colonoscopy or a phlegm-sigmoidoscopy, right? If you don't know they have one or the other, you have to do some type of procedure to diagnose and confirm with a biopsy. You could elect to do a phlegm-sigmoidoscopy first instead of a colonoscopy, but if you find Crohn's disease, then you will have to do a full colonoscopy. Okay? It's unclear how long you treat the flare of the disease. It depends on the disease. It could be a couple of weeks, it could be a couple of months. It depends on the severity of the disease. You don't know that. Okay? All right, very good. Some people will continue mesalamine because this also helps with the flare of the disease. Okay? Guys, I said if the person comes in with a flare but you don't know it's inflammatory bowel disease, you have to do a procedure. I know it's late, but you have to do a procedure. If you know the patient has UC and comes in with a recurrent flare, you don't have to do a colonoscopy or a sigmoidoscopy. But if this patient comes in undiagnosed, you're going to have to do with one or the other. Everybody understand that? I see what's right in there. I'm getting worried because this is straightforward. But what do you guys need to confirm? I mean, if you don't do the colonoscopy or the sigmoidoscopy, you can't make a diagnosis. Didn't we say that? The most common drug that we use for maintenance is 6-MP. Not everybody believes in that, but that's usually the drug of choice. Okay? Everybody okay with that? We're past diverticulitis, right? We're not, in diverticulitis. diverticulitis land. This is inflammatory bowel disease land. Okay, you have to make a diagnosis here. So yes, there's a risk of perforation when they have a flare, but there's no other way to make the diagnosis. Okay, all right. So here's a couple of things that you guys have been a little bit, questioned about. So be careful about total colectomy. Okay, total colectomy is with a treatment intent. Good. Rodrigo says in UC only. It's with a treatment intent. All right? Everybody understand that? Right. So if you have a lot of complications, a lot of flares, right? One of the considerations, I'm not saying you go straight to colectomy, but one of the considerations is to do a total colectomy only in ulcerative colitis. So not in Crohn's disease. Crohn's disease, a colectomy is only done if you have some kind of complication. Anybody know why? Why don't you do it in Crohn's disease? Because it recurs. Arthur said it recurs proximal to the surgical site. So you don't want to do it as a contraindication for therapeutic intent, right? But if you got fistulas, you got perforation, you got obstruction, okay, then you gotta do it for other reasons, right? Everybody understand that? So this is a very important issue of inflammatory bowel disease. Also, infliximab. Infliximab. What's infliximab? What's infliximab? This is the biologics now. Everybody's using this stuff. Anti-TNF. All right. Very good. All right. So there hasn't been enough studies in ulcerative colitis, but in fistulizing Crohn's disease, right? This is one of the great options now because before Crohn's disease, was rampant. You couldn't do anything about it, right? They say that these, break down or inhibit the granuloma formation, the inflammation, right? You have to do a PPD in these patients before because you run the risk of tuberculosis, right? So Chitra says you do a PPD. You actually do a PPD and you get a chest X-ray too, right? So be careful. They may ask about infliximab use. What do you need to do before? The answer is PPD and a chest X-ray. All right. So be careful about that. So don't use it in ulcerative colitis. Once you put the patient on infliximab for Crohn's disease, you can't take the patient, right? You can't take the patient off. So now you got them on $35,000 treatment per year, right? And then they're lifelong. We don't know what this means. What happens if you use infliximab for 20 years? We don't know. This is uncharted territory. Art says, can you use PPD? Can you use infliximab with a positive PPD? Right? The answer is yes. You treat it first with isoniazid. Right? You treat it. Right? Treat the TB, and then do the infliximab. Either at the same time or afterwards. Right? Because you're worried about activation tuberculosis. You treat it, right? And then you use the infliximab. Okay? Or at the same time. Everybody okay with that? They may ask a different question. Somebody on infliximab gets, febrile syndrome and stuff like that, gets cough. What do you need to worry about, right? The answer is, basically tuberculosis. Okay? All right, very good. All right, a couple more things. So we talked about ulcerative colitis. This is usually in young people, although there's a second peak. It has a bimodal distribution, so you could see it in 50 and 60-year-olds. And then there's a strong genetic predisposition. This is possibly, most people think it's immune mediated. This is the also the ones that associate, sometimes people say, with some environmental factor, sometimes infections and stuff like that. So it presents with bloody diarrhea and abdominal pain, right? It has tremendous variability, right? Either mild proctitis, very limited, right, to fulminant pancolitis. That's the one you have to do colonoscopy if you're going to see the extent. Okay, these patients have increased risk of cancer, adenocarcinoma of the colon. When they get pancolitis, 10-year duration and above, right, these patients have 10% risk of colon cancer. So they need to have a colonoscopy, right, and biopsy if you see anything strange there. They usually have it every couple of years. Some people say if they have it for 20 years, they have to get a colonoscopy every year to 6 months. So some patients will say, well, I'm not going to do that. Let me just get a colectomy. That's one of the reasons why they get a colectomy, right? All right, very good. So we want to know the differences, right? We want to know the differences between Crohn's and ulcerative colitis, right? Crohn's disease has skip lesions, transmural granulomas, fistulas, and abscesses. These fistulas because the lesions are transmural. They sometimes develop obstruction because, again, they're transmural. They may have perianal disease sometimes. Remember, Crohn's disease is where? Can occur from the tip of the mouth to the tip of the anus, right? Anywhere with any skip lesions in between. Ulcerative colitis is considered curable by surgery. I'm not saying go there right away, but if you do a total colectomy because it's a continuous disease, it's with curative intent. It's entirely mucosal, no fistulas, no abscesses, no obstruction, no fistulization, right? And there's 100% rectal involvement, 100% rectal involvement, but usually no perianal disease. So this is 100% rectal. Crohn's is about 40% rectal involvement. Okay, so those are the differences. We have to know the differences for the USMLE. We have to know differences on the biopsy and so forth. Okay, so this is 40% rectal, right? So when they say, which inflammatory bowel disease presents with bloody diarrhea? The right answer is both, because you need rectal involvement to have bloody diarrhea. In ulcerative colitis, they all have. In Crohn's disease, half of them do, about 40%, less than half, right? But so anyone can present with bloody diarrhea. If you have inflammatory bowel disease that does not present with bloody diarrhea, then it has to be Crohn's. Okay? And then this is what you guys were talking about, some adjunct tests. These adjunct tests, please, they're not the gold standard. The gold standard is the biopsy. Some people use these adjunct tests just as, look, this is an immune disease. This is probably something to do with the environment. So anti-neutrophilic cytoplasmic antibodies are positive in UC. C-ANCA, P-ANCA are positive. C-ANCA is Wegener's disease, right? Wegener's. These are P-ANCA. And then anti-Saccharomyces cerevisiae, right? That's a fungal infection, right? So that's usually positive in Crohn's disease, but we don't care. I mean, this is, an insight to what this disease is all about, but, the truth of the matter is we need the biopsy. Okay? All right. Remember, colorectal cancer, right? Follow-up, all right? Colonoscopy is started about 8 to 10 years after diagnosis. Does anybody know what's the other cancer these patients are prone to? It's much rarer than colorectal cancer, but certain number of these patients get another cancer. Primary sclerosing cholangitis. So they get primary sclerosing cholangitis, right? Obstructive disease now. So they ask about that. A patient with UC coming in with jaundice, et cetera. What do they have? Sclerosing cholangitis. And these patients, years later, right, may get cholangiocarcinoma. It's only the people that get primary sclerosing cholangitis, right, that eventually get the cholangiocarcinoma. So the two cancers that people with inflammatory bowel disease are associated with is colorectal cancer, right, adenocarcinoma, and cholangiocarcinoma. Okay, very good. Okay, so this guy now, case 8, has severe dull abdominal pain. This guy is a 32-year-old guy with a history of alcohol abuse, comes to the ED with 2-day history of increasing constant dull epigastric pain that radiates to the back. All right, so what are the pains that radiate to the back? So acute pancreatitis, so be careful. Use the right terminology. Acute pancreatitis, right? And the other one, Juan says, is aortic dissection, right? Usually it's in the chest though. Right? That's right. So the two diseases that pain radiates to the back, if it's in the chest, right, it's aortic dissection. You got to worry it's aortic dissection. And then if it's in the abdomen, it's usually pancreatitis, acute pancreatitis, right? Not chronic pancreatitis. Chronic pancreatitis is a malabsorption syndrome. I use the right terminology. Okay? Right, so you could get even an abdominal aortic dissection. Okay, I said likely it's acute pancreatitis. Okay? All right. So this person has 2 episodes of emesis without blood. He admits to an alcoholic binge yesterday, denies prior history of similar episodes, denies history of trauma or medication. Right? So it sounds like the right history here. Right? A binge recently, now comes in with the abdominal pain. Okay? All right, very good. So the temperature is 99.9, the blood pressure is a little bit on the low side, the pulse is 100 per minute, right? And then he is orthostatic, right? You sit him up and the blood pressure drops and the pulse goes up, so he's orthostatic. His heart is tachycardic, his lungs are in normal limits, his abdomen has decreased bowel sounds, tenderness to palpitation. In the epigastric region, there's no guarding or rebound. Rectal examination is negative. All right, so what do you guys think? Does this make sense? So it sounds more like what? All right, so no, it said no rebound. No rebound. So you think about it, perforation, but no rebound. Right, but he's definitely unstable, this guy, right? Christina says unstable, right? So orthostatic, dehydrated, right? That would make sense. That occurs with acute pancreatitis, right? All right. So pancreatitis is definitely a possibility, especially in the alcoholic patient, right? The other thing you got to think about, of course, is peptic ulcer disease with perforation, right? Even though, despite this patient doesn't have any guarding and stuff like that, you still have to think about it. Right? This guy didn't have a history of peptic ulcer disease and stuff like that, but definitely that's the other thing to think about here. Right? Aortic abdominal aneurysm with dissection would be the third thing I would think about here, right? Because that also presents with pain to the back. Okay? So what's number 1 here? The first thing we do, what do we always do? We stabilize the patient, right? We always stabilize the patient. Remember, what are the numbers when we give them fluids? In GI processes, what are the 2 numbers we think about? 90-90, right? Keep blood pressure above 90, keep heart rate less than 90, right? Everybody okay with that? Okay. We want to get some baseline tests, right? Like a CBC, a chemistry profile, right? And so now, what if they ask us, what is the best single test? The best single test to diagnose acute pancreatitis. So you got one chance, right? So the answer is the lipase, right? That's probably the most sensitive and specific. And so one test to diagnose acute pancreatitis, kind of like a blood test, right? So lipase. So maybe the CAT scan is even more sensitive and specific, right? But I was thinking more of a blood test. So they even got an abdominal x-ray to make sure this patient doesn't have perforation. Some people will get a chest x-ray, right? Because we said that's the best way to see for air under the diaphragm, right? So these are good tests. You guys may elect to do more. You may get a CAT scan to make sure there's no perforated organ. That's okay. In this case, it makes sense. Okay? So we place large bore catheters and start the fluids. All right, what are the typical fluids that we start? Normal saline, right? Okay, very good. Okay, the white cell count is elevated, 15,000. The glucose is elevated. Uh-oh. The calcium is low. Boy, so this guy has low calcium, elevated glucose, right? And the amylase is definitely elevated. So is the lipase, right? The chest x-ray and the x-ray of the abdomen are normal. Okay? All right, what do you guys think? So the lipase is elevated, so is the amylase. All right, so now we've pretty much confirmed acute pancreatitis, right? All right, so what's the elevation of white cell, right? Elevation of glucose mean? Low calcium. Low calcium in acute pancreatitis means like systemic inflammation. There's a lot of, pancreatitis, maybe even necrosis, right? So all these things here, this is not good prognosis. This is part of the old Ranson's criteria. Most people don't use a lot of the Ranson's criteria anymore. They use Apache scores, or they just look at a couple of these things, right? So, but the two ones you got to remember, right, that are bad prognostic indicators is the glucose that's elevated, right? So that means that enough of the pancreas has been involved to involve the beta cells, and then the calcium is low. That's also bad, right? That's also bad. So this guy I gotta watch, right? I'm gonna watch now. Maybe put him in the ICU. Maybe get a CAT scan too to look for severe necrosis. We don't do CAT scans in every person with acute pancreatitis, but when the patient's not getting better, or when we think the patient may have severe forms of pancreatitis like this guy, then you want to see, because you want to see if they have an abscess, you want to see if they have a lot of necrosis, right? And stuff like that, right? Because you may change your management in this case. If there's an abscess, you may get, surgeons to drain it. You may give them antibiotics and so forth, right? Okay, very good. So a little bit further down, right, we need to remember people presenting with pancreatitis and abdominal and flank ecchymosis, right? So this is when they have periumbilical ecchymosis. It's colon sign. When they have flank ecchymosis, is called the Gray-Turner sign. So this is evidence of necrosis, hemorrhagic pancreatitis. This is bad prognosis. So they ever show us a picture of that, we need to put this patient in the ICU. We need to do a CAT scan and so forth. Okay, so the acute pancreatitis is pretty much given in this patient. He's got a history of alcohol abuse. The pain radiates to the back, which is typical, right? There's no rebound tenderness that goes against the perforated ulcer, although that still should be thought of. This patient has low-grade fever, which is consistent, increased white cells, right? Watch the electrolyte problems, especially the hypocalcemia, and of course, the confirmation by the elevated amylase lipase, especially the lipase. The lipase is more sensitive and specific. So no features that should localize to the gallbladder or anywhere else. Okay? All right. So now we need to know the causes. All right. So let me tell you, most causes of acute pancreatitis are idiopathic, all right? Non-idiopathic, you're going to know four things. Number one, out of the non-idiopathic, right? And two is alcohol and gallstone, okay? You also have to remember hypertriglyceridemia, right? And post-ERCPs. Post-ERCPs, about 10% of them, you get acute pancreatitis. You get mild forms of acute pancreatitis, but you have to be on top of it, okay? But look at here. The most important things here is gallstone and ethanol, okay? So watch it. Gallstones. You always have to exclude gallstone, even in drinkers. All right, don't think that because this guy is a drinker, they got acute pancreatitis from that. It's likely the case, but you have to exclude gallstones. Okay, the CAT scan on further management shows diffuse pancreatic edema with extension to the pancreatic fat. All right, so you confirmed he's got extensive necrosis. Okay, fine. All right, so now what do you do? How do you manage this? So I want to know, what do you do? All right, what are your orders to the nurse? What pain medication you're going to put? So maybe I put him in the ICU because he's got a lot of, right, abnormal findings. Okay, fluids, NPO, morphine. Okay, and Sarah says maybe antibiotics. Your antibiotics is like plus or minus unless you see an abscess there. So maybe with extensive fat necrosis, some people say, okay, there's some studies that maybe show some benefit if you put them on imipenem or something like that. Okay, now that is questionable. If you put them on, if you see an abscess there, yeah, right. But with this guy with the extensive necrosis, it's unclear. So some people swear by it. So some experts say yes, right? But the standard stuff is the NPO, the morphine, the IV hydration, right? That we know works very well. Everybody okay with that? All right, very good. So we did nothing by mouth, right? Morphine, IV hydration, right? So we say like if necrosis, if a lot of necrosis, maybe imipenem, right? Okay, maybe even surgical evaluation if you see an abscess there or something like that. And then eventually, please make sure in every patient with acute pancreatitis, an ultrasound of the gallbladder to rule out acute pancreatitis as being caused by gallstone pancreatitis. All right, so be careful because this now is correctable. And if you don't correct it, it's going to happen again and again. All right, so very, very important. All right, so the pseudocysts usually need drainage. Usually it's a surgical consult or interventional radiologist. Okay? Everybody okay with that? So what are the two most common causes? The two most common causes of acute pancreatitis, alcohol and stones. What do we, yeah, right. I said the identifiable ones, right? Because you're right, idiopathic is the most common one. So you alcohol and gallstones. Make sure you look for stones. What are the other ones we have to keep in the back of our mind? Hypertriglyceridemia and ERCP, post-ERCP, 10%. All right, so they had this case where they present this guy with abdominal pain and they show you, yes, trauma, scorpions, stings and all that, interesting stuff and medicines and things like that. But I told you, these are the four you have to remember. Okay, be careful because they showed a patient they didn't show the patient. They had somebody presenting with abdominal pain, right? And they showed the blood, right? And the blood was lipemic. It looked yellow, right? They expected you to know that this patient had hypertriglyceridemia. Everybody okay with that? All right, very good. All right, so you got to know that that patient has triglyceride pancreatitis. Okay? Okay, very good. If they ask about medication, right? If they ask about medication, so cause of death in acute pancreatitis is rare, but it's multi-organ damage like ARDS, acute respiratory distress syndrome, sometimes, perforation and stuff like that. Everybody okay with that? Okay, very good. Right. All right, very good. If they ask you about medication, so a lot of medications have been implicated. Good. Massar said HIV medication, DDI, right? AZT, exactly. Hydrochlorothiazide has been implicated, right? So listen, if anybody gets pancreatitis, acute pancreatitis, what are you going to do? You're going to pull them off the medication right away, right? A lot of the medications, if you could use anything else, take them off, okay? Don't risk it. Okay? All right, so we talked about this idiopathic. Some people say, this is biliary microlithiasis. Okay? All right, very good. All right, last case, and we'll finish up. Okay, so this person says, my 65-year-old father, uh, is jaundice. Okay? This patient has a 2-day history of fever, right upper quadrant, abdominal pain, and jaundice. The patient daughter noticed that his skin color has changed progressively in the last 2 days. So, right, fever, right upper quadrant pain, right, and jaundice. He feels very tired, right, and has rigors and diaphoresis. All right, what's the disease you think about? Fever, jaundice, right quadrant pain. Well, you think about hepatitis A too, Alfred. I definitely about that. So usually hepatitis A, they got a little bit of pain, especially if you put pressure on them, right? So it can't be only cholecystitis because cholecystitis doesn't cause jaundice. But you have to have what? You have to have a common bile duct stone making obstruction and causing the jaundice, right? Right? That's what stuff I think about. I think about cholangitis, acute viral hepatitis, right? Everybody okay with that? So this patient has almost 103 fever, blood pressure is low. Oh, you're in trouble here, right? The pulse is elevated, right? So this patient has, sepsis-like syndrome, right? There's significant tenderness in the right upper quadrant. His sclera are ecteric and his skin is markedly jaundiced. He denies any respiratory distress. He's difficult to arouse. Oh boy, this guy's sick. He's got no significant past medical history, but did recently have postprandial right upper quadrant pain that resolved on its own 30 to 45 minutes later. So it sounds like what? It sounds like this patient had cholelithiasis and eventually a stone went to the common bile duct, obstructed it, right? And maybe, right, caused the infection with the obstruction, right? So sclerosing cholangitis, biliary cirrhosis don't cause infections. These are chronic autoimmune diseases, right? So then you got to be worried about here cholangitis and acute hepatitis. Okay, so you're thinking about ascending cholangitis. I would be thinking about acute hepatitis, although it doesn't go with all the pain. Primary sclerosing cholangitis is a chronic autoimmune disease, right? cholecystitis would be a possibility, right? But where do you get the jaundice? And choledocholithiasis would be a possibility, right? Also, but you have more stone obstructing. Okay? All right. So this patient is unstable, right? So for unstable patients, what do? Right? We stabilize them. We put two large bore IV lines and start fluids, usually normal saline. What do? We keep the 90-90. Blood pressure, systolic blood pressure over 90, heart rate less than 90. We obtain basic labs, right? If the patient is really confused, sometimes we intubate to protect the airway. Watch this. This is not because the patient has respiratory distress. We intubate because we want to protect the airway. So you could use either normal saline or crystalloid, which whatever you like best. You could flip a coin. They're both the same. So going back here, this is important because these patients get aspiration, right? So you want to make sure that you stabilize the patient, and if they're confused and stuff like that, you protect the airway. Some people will insert a catheter. They don't have to put an invasive catheter. They could put a Texas catheter on to measure urine output and get an idea of what's going on with the kidney, right? So first rule here is stabilization. Okay, that's our first thing. All right, so the hemoglobin comes back and it looks pretty okay. The white cell count is definitely elevated, right? The platelets are low. Boy, this guy's maybe he's having, even DIC, right? The sodium looks okay. The BUN is elevated. So this is elevated. This patient may have early renal injury. The creatinine is also elevated. The bilirubin is definitely elevated. It's mostly direct. The ALT is elevated, and so is the alkaline phosphatase, and so is the PT and the PTT. So you guys have to be able to put all this together. So this is a nice case for you guys to figure this out. So, okay, so we understand, all right, so this guy's got a stone obstructing, right? So the bilirubin, the direct bilirubin goes up, all right? Because of the obstruction, this patient has an infection. Remember, what did we say? What organisms are associated with infections of the gallbladder and stuff like that? So it's E. coli. This patient has hypotension, so they're having like septic shock. Okay, what's the PT-PTT elevated for? Right? Why are the platelets low? The patient's having DIC, right? Listen, it's got to all fit. This guy can't have ascending cholangitis and then have viral hepatitis, right? Now you think about liver damage, right? Fulminant hepatic failure, but there's nothing here to point towards that. Fulminant hepatic failure from what? Right? It's probably DIC, right? A consumptive coagulopathy. Okay? All right, so give me some antibiotics that I would give this patient. Good. So piptazo, right? Or Zosyn. You guys love this, right? So it has anaerobic coverage, right? And gram-negative coverage. You may use combinations of ciprofloxacin and ceftriaxone. That's also good, right? Unison is good. Be careful though. It doesn't get severe gram-negatives. See, the piptazo is good because it gets everything from Pseudomonas to E. coli and Klebsiella. Unison you got to be careful about. All right, so I would either do double gram-negative coverage with Cipro and ceftriaxone and stuff like that, or Pip-Tazo, right? Something like that, right? That has broad coverage. So what this patient has, yeah. So the other one would be imipenem. If you use imipenem, Bruno, you don't have to use third generation cephalosporin. You use imipenem, that has pretty much broad coverage on its own. If you use third generation cephalosporin, you probably have to do additional coverage. Okay, so this is sometimes referred to, what this patient has, as Reynolds pentad, right? So where you have jaundice, fever, right abdominal pain, right, altered mental status, and shock, right? And that's usually due to ascending cholangitis. Ascending cholangitis is caused by an obstruction, most commonly a gallstone, right? But sometimes rarely from other obstructions like cancer. So I've seen cancer do this sometimes. And patient has some kind of remote history of biliary colic. So like this guy said, he would eat, and get the biliary colic, and then eventually got the obstruction with the ascending cholangitis. So we have to initially resuscitate this patient, right? This patient has hemodynamic instability from biliary sepsis. So where do we send this guy, right? They have to go to the ICU, right? Once the patient has been stabilized, then we work more focus, right? So we said the E. coli is the most common cause of biliary sepsis, right? And the further management in this patient is resuscitation, and then we go nothing by mouth. We use Pip-Tazo or imipenem or a combination of cephalosporin and fluoroquinolones. Some people may use combination with metronidazole also. We use a lot of hydration. And then eventually, all right, so this is the important thing, eventually, once this patient is stable, you're going to get your friend, the gastroenterologist, to come in, right, and remove the stone in the acute setting. And then eventually you're going to have to do a cholecystectomy. Okay? But right now, a stone in the common bile duct is really the main reason to do an ERCP, right? An ERCP is what? You do an upper endoscopy, you go through the second part of the duodenum, right? You cannulate, right? And you go up the bile ducts. You shoot dye up the bile ducts. The ERCP is good. Why? But it's diagnostic and therapeutic, right? You cut the stoma there, you release the stone, right? You cut the sphincter, right? Sphincterotomy, you release the stone. Okay? Everybody okay with that? Now, ERCP may cause pancreatitis, but in this case, you have to do it. Okay? You have to remove the obstruction, or this patient's sepsis syndrome is not going to get better. Ascending cholangitis, right? Emergency. I mean, it's not elective, right? It's not elective, right? So whether you do it in the first or second day or the third day, it doesn't matter, but it's a semi-emergent basis, right? This is not an elective ERCP, right? Right, so you cut the sphincter, you release it, right? And you get drainage. Okay? Obstruction, right? The infection should be, improving. Okay? Everybody okay with that? All right. I'll stop right there. All right, and I'll see you guys in 2 weeks. Now we want to thank everybody, Dr. David, Dr. Mark, Chris, thank you so much. Thank you everybody for your attention. So there's no specific time to do the ERCP, but the sooner you stabilize the patient, right, the better you could do the ERCP, right, and remove the obstruction. That's what you eventually want to do. Okay? So next time I see you guys, which will be in not this weekend, right? The weekend after that, we will do a we will do it endocrinology, right? That I don't know what's on for tomorrow, guys, but when we do it in 2 weeks, it's endocrine and infectious disease. Okay? All right. Thank you so much for your attention, and I'll see everybody in about 10 days. All right? All right. Have a wonderful night. Take care, everybody.